Good morning, everyone.
Morning.
Good morning, sir. YouTube screen idle.
Yeah, you continue. Continue. Please continue.
Good morning, everyone. It is with great pleasure and immense gratitude that we warmly welcome you all on behalf of Kasaragod Ophthalmic Society to join us for the Scientific Committee CME 2022 Module 3 on this pleasant Sunday morning. Preserving Sight Under Pressure, an apt title to discuss the enigma that is glaucoma. Our module has been divided into 4 crisp sessions with renowned speakers from all over India who are exemplary in their field of work. Without further delay, let us commence this forum with a silent prayer. Now I invite our beloved President of Kasaragod Ophthalmic Society, Dr. Rahim, to deliver the welcome address.
Sir, muted on, sir.
Okay, yes. I think, is it audible?
Yes. Yeah.
Yes. Is it audible?
Yes, sir. Yes, sir. We can hear you.
Okay.
Rahim, sir, you can start, sir.
We can't hear?
No, sir.
No. Suresh Babu, you can start.
Yeah. Very good morning to all.
Yeah.
Yeah. Am I audible?
Yeah.
Kasaragod Ophthalmic Society is very proud and privileged to conduct the 3rd module of CME series of Ksos titled Preserving Sight Under Pressure. We are all the more happy to have a CME on glaucoma update on the first day of World Glaucoma Week. And the theme World is Bright, Save Your Sight. Respected colleagues, let me come to my duty. In the absence of my president, I am taking over this duty with the instruction of the Scientific Committee Chairman. First, let me welcome Dr. Arup Chakravarti, sir, President of Kerala Society of Ophthalmic Surgeons, the Indian ophthalmologist of international repute, a visionary leader and a great teacher who will be inaugurating the CME. Hearty welcome to you, sir.
Thank you.
Next, let me welcome our dynamic KSOI Secretary, Dr. Gopal S. Pillai. Welcome, Gopal, to Kasaragod Ophthalmic Society CME. Let me welcome our energetic and dynamic Scientific Committee Chairman of KSOS, Dr. Srini Adaklon. Welcome, Dr. Srini.
He has taken the...
I am happy to welcome Dr. Sujit Nayanar, the Scientific Committee member, KSOS, in charge of our CME. I am happy to welcome the keynote speakers of the day, Dr. Shantha of Shankar Netralaya, Dr. Rajul S. Parikh of Sri GI Clinic and Parikh Glaucoma Care Center, Dr. Swathi Upadhyaya, Aravind Eye Hospital, Pondicherry, Dr. Susmitha Kaushik of PGI Chandigarh. I am happy to welcome the chairmen of the 4 sessions, Dr. Bindu Ajith of Compressed Hospital, Calicut, Dr. Kiran Gopalakrishnan of Precise Eye Hospital, Trivandrum, Dr. Saikumar SJ, Giridhar Eye Institute, Cochin, Dr. Thomas George, Chaitanya Eye Hospital, Trivandrum. And I also welcome the panelists of the 4 sessions. A special welcome to Dr. Venkatesh, who has agreed to become a panelist of session 3. I'm happy to welcome the KSOS members, non-KSOS members, members of Kasaragod Ophthalmic Society, and the technical team. Once again, welcome you all. Thank you.
By Suresh Babu. Thank you, sir.
Thank you, sir, for your warm words. Now let us go to the official inauguration of the CME. I welcome our most honorable president of KSOS, Dr. Arup Chakrabarti, who has kindly consented to inaugurate the scientific module. Sir, I welcome you to deliver the inaugural address.
Any lamp lighting is planned for?
No, sir. No, sir.
No, okay, because, yeah. So, good morning, friends. I'd like to thank Kasaragod Ophthalmic Society for giving me this opportunity to inaugurate this very important and prestigious webinar. And we are, all of us know that we are going through that period of the year where the whole world observes World Glaucoma Week. There are a flurry of activities happening all over the world. KSOS has been doing it for quite a number of years, but this year is special. And KSOS, under the initiative of Dr. Gopal, our secretary, Dr. Srini, scientific committee chairman, and the other executive committee members, with their blessings, we have embarked on a unique journey to make this entire program, entire week observance, a very vibrant one. And this is the curtain raiser. This is the first program that is happening today. And I'm very happy to see my good old friends, Dr. Rahim and Dr. Ganesh from my Arvind days, and other friends, Dr. Sudesh and Dr. Rakesh, who have taken a very important leadership role in this particular CME series. More about it a little later. And let me just apprise you of the plans of KSOS to observe this particular week from 6th to 12th. As I mentioned, this is the opening webinar. A lot of good topics have been arranged and the good speakers. And today evening, we have a very unique, a landmark program wherein KSOS stalwarts will interview the Dr. Padma Shri Dr. S. Tony Fernandez, who is a renowned authority in the field, in the country, as well as in Kerala. So this a little bit about this effort. You know, this is part of our eye literacy drive for this year, where we are taking up public awareness programs through the help of Dr. Srini, through the help of Dr. Gopal, Dr. Saikumar, Dr. Meena, and many others, wherein we'll have a very vibrant interface between KSOS and the public. And we have taken a unique step in the sense that we have collaborated or have a tie-up with marketing agencies who will do the social media marketing for us. And we hope through this venture, we succeed in educating the public, creating awareness amongst the public's mind about all kinds of ailments and issues and factors that a patient need to know for better ophthalmic care. So that is happening today evening. Then subsequently we have an interview with a very prominent ophthalmologist, Dr. Ajith Sehota, that also happens to commemorate the International Women's Day. And on the same evening, we'll have an online journal club, the third journal club. Actually, it was supposed to be on a different topic, and we changed the topic to glaucoma this year, just so that it fits into this particular window of World Glaucoma Week. Just give me a minute. Just a minute. Yeah. So, and then we also will have a postgraduate case discussions, and ultimately the program will wind up with an interaction with Professor Sahasranaman. I'd like to thank Srini and Gopal for organizing this this CME module 3, and we have international speakers of international repute, Dr. Shantha, Dr. Rajul, Dr. Susmitha, and Dr. Swathi, the new kid on the block, who has done a lot of work on MIGS And we have a lot of KSOS stalwarts participating in this program. And with these few words, I would like to inaugurate this meeting and wishing the entire meeting as well as the World Glaucoma Week program for KSOS all success. Thank you very much.
Thank you, sir. Thank you, sir, for inaugurating the CME. On behalf of Kasaragod Ophthalmic Society, we sincerely wish you the very best for all your determined endeavors to elevate KSOS to further national acclaim. Now let us invite the Honorable General Secretary KSOS, Dr. Gopal S. Pillai, to felicitate the CME.
Thank you very much, Stephanie. So it gives me immense pleasure to stay within your midst to actually talk to you about this wonderful program. Actually, I'm told that this is the first program that Kasaragod Ophthalmic Society has been conducting over the last few years after COVID. And hats off to you, my dear colleagues from Kasaragod. It's really a wonderful start. And I hope that this start, which I think is pressurized by none other than our vibrant scientific committee chairman, Srini, will push you to do more such programs, probably 3 or 4 programs in the year, which is not a very tough task to ask. With leadership like Rahim sir, as well as Baradan sir, as well as Suresh Babu sir, all these people are there. So I think definitely 4 or 5 programs a year may not be too much to ask. So as Arup sir told us, see, Arup sir has been pushing both of us, Srini and myself, to do this and to do that. Every day there will be one call to say, have you done this? Have you done this? Have you finished this? Have you done this? That needs to be done. So he pushes us to perform. And let me tell you that this glaucoma week is going to be a flurry of activities, like he said. March 6th, right now, we are in this CME. Then evening today, we have the great Tony Fernandez sir talking to us about eye conditions. Then March 8th, we also have the doubled up World International Women's Day, where Dr. Ramanjit will be sharing with us her journey as a woman ophthalmologist to reach the pinnacle of glaucoma. Then we will have this Journal Club in Glaucoma, which is spearheaded by Sudha Madam. And then in March 9th, we have a PG case presentation on glaucoma, which is another program that we are starting, a PG case presentation, which will be done every week. And then on the March 10th, we have the mega glaucoma screening program by almost 150 hospitals across the states. Each district club is involved in that activity. And March 12th, this will culminate with an interview with the versatile Professor Sasram sir. So this is a very busy week for us. And this program is really amazing because it covers 360-degree glaucoma in half a day. And it has all the stalwarts, all the who is who of glaucoma in the country. And all the best to this program and all the best to Kasaragod Ophthalmic Society. Over to you, Stephanie.
Thank you, sir. Thank you, sir, for honoring us with your presence in the CME and your vision for KSOS. With great reverence, I invite our KSOS Scientific Committee Chairman, Dr. Srini Edaklon, to felicitate the CME.
Thank you, Stephanie. Thank you, Arup sir, for inaugurating the CME. As Gopal said, this is probably the first major program. So because by the Kasaragod Ophthalmic Society, Kasaragod Ophthalmic Society was a co-host for Drishti 2019, but as something that is being held directly through them, this probably is the largest, and they've been doing small programs. But see, we have to get all these clubs to think big. And this is what we aim to achieve through our scientific committee CME series. And with my members, really vibrant members like scientific committee members like Sujit, Thomas George, and Prashov, see, we are able to guide these clubs who are not like unlike TACO and COZ, who are not in the habit of constantly conducting programs. Like for this program, Sujit and Thomas George played a major role in planning the program, inviting the faculty, because Dr. Thomas George is a very major name in glaucoma in India. So he has a lot of contacts. So all the faculty were invited through him. Kiran is another big name in glaucoma in India. So Kiran also played a major role in planning our program. Dr. Sai is there, one of the top names in glaucoma in Kerala. And Dr. Bindu, definitely the one of the most energetic and most efficient glaucoma specialists in Kerala. So we have four dynamic chairpersons leading these four sessions, and you can expect a wonderful program with the four great keynote speakers. In addition to these four great keynote speakers, we have invited faculty as discussants also. Dr. Venkatesh from Pondicherry, Dr. Meena from Shankara Bangalore, Dr. Ajith from Shankara Coimbatore. So, and our wonderful state faculty. So we can expect a really great CME. And see, every time, with each CME, the first CME was done at Calicut, the second by Kannur. See, the program in Kannur has made the Ophthalmic Society of Kannur vibrant. We are planning, as Gopal says, a flurry of activities now. Dr. Simi and team are doing it. And after this, I'm absolutely sure that Dr. Rahim will lead the Kasaragod Ophthalmic Society to major programs by Kasaragod Ophthalmic Society. So, see, the way Stephanie has been moderating all this, calling us and what do you call, VJing or what? So she's the MC actually. So she, I mean, we didn't have this for the first two. So Kasaragod had a meeting yesterday and they planned everything properly. You can be sure that there won't be any hitch in this program. And a big thanks to Ankit for being our IT man, and he's doing a wonderful job there. And a big thanks to Milmet, especially Sarjan, for sponsoring our CMA series programs, and they are involved in other help to Ksos also. So we will have a really great meeting, and a request to all of you to share today evening's interview with Tony sir's link with all your friends, family members, and everyone, so that when 1 hour with Dr. Tony, I mean, ophthalmologists will learn a lot. The general public will learn a lot. The only issue is that people should know that such a program is happening. So I request everyone to share the link with all your friends and colleagues. And definitely the glaucoma screening camp that is going to happen on 10th is going to be a major event. This is the first such event all across the state, glaucoma screening happening. As Gopal said, 100 to 150 hospitals doing it. The first time in India, and probably if you take an area-wise, the first time in the world such a thing is happening. So we're looking forward to a lot of activities from Gopal and Arup sir for the rest of the week. And thanks once again, Kasaragod Ophthalmic Society. Back to you, Stephanie.
Thank you, sir, for those wonderful words. Now let us welcome our beloved KSOS Scientific Committee member, Dr. Sujit Narayanan, to felicitate the CME.
Thank you, Stephanie. Thank you, Kasargod Ophthalmic Society, for making me part of this CME series and inauguration session. As Srini sir said, I just summarized, like the KSO CME series was actually started with the intention of pushing all the clubs into making, conducting more programs, because the smaller clubs were finding it difficult, like in smaller clubs in terms of the number of members in the club. So they were finding it difficult to come into the mainstream, conducting bigger programs and conducting more number of programs. The online mode has made it more easy for all of us. So it's just we need to push them into this. And that's what Dr. Gopal, Dr. Srini, and Arup sir and all are doing. We are just helping them to facilitate the various clubs to conduct better programs, bigger programs, and more number of programs. Because in this physical scenario, it was more difficult because of difficulties in the logistics, the cost involved. Now with the online, it is much more easier. So we just need to push them, we just motivate them. And I was like extremely surprised to see the enthusiasm shown by the Kasargod team led by Suresh Babu sir. Actually, from the word go, they were too much into it. They were conducting, as Srini sir told, they were conducting a lot of trial meetings. Last night also there was a meeting. They conducted the entire inauguration session and just saw that there is no glitches. That's why when the welcome speech got stuck, there was Suresh Babu sir to take over it, and nothing went wrong there also. So like every member club can do this, and Srini sir, the scientific committee, Gopal sir, it's a nice initiative, pushing all clubs into it. They showcase that I must appreciate the enthusiasm shown by the team spirit shown by the Kasargod team in conducting this program, just like what they should have, or they would have done for a Drishti program. So special congratulations to Kasargod team for showcasing this team spirit. And we hope to have a very informative CME with all the stalwarts of KSOs and AOs here in one stage today to mark the, we have a very good beginning for our Glaucoma Week program. I wish this CME a very great success. Thank you.
Thank you, sir, for those kind words. Let me now invite our most respected treasurer, Kasargod Ophthalmic Society, Dr. Ganesh Maya, sir, to deliver the vote of thanks.
Good morning, everybody. At the outset, my sincere thanks goes to KSOS for bringing our Kasargod club to the mainstream. Thank you. So at the outset, I thank our my teacher, dynamic leader of KSOS, Dr. Arup Chakravarti, for inaugurating our CME series, Module 3. Thank you, sir. Thank you for inaugurating this session. I thank our Honorable General Secretary, KSOS, Dr. Gopal Pillai, Honorable Dr. Gopal Pillai, for addressing us and blessing us. Thank you. Thank you, sir. My sincere thanks on behalf of Kasargod Ophthalmic Society goes to Dr. Srini Edakan, Vibrant Secretary, KSOS Scientific Committee. He is the main person who made us to involve in this CME series and bring us into the mainstream. Thank you, Dr. Srini. Thank you, Dr. Sujit, for your ideas, plans, and kind words. Our sincere thanks go to our Honorable President, Dr. Rahim. Sincere thanks go to Dr. Suresh Babu, and my sincere thanks go to Dr. Stephanie for anchoring this session. And more important, my sincere thanks to today's main keynote speakers, Dr. B. Shantha, Dr. B. Dr. Rajul, Dr. Swathi, and Dr. Kaushik, for those who are present here. And my sincere thanks to Milmet, Sun, and once again I thank you to webinar. Thank you, sir.
Dr. Shantha, Dr. Swathi have entered our program. Welcome you, ma'am.
Thank you. Good morning, everyone.
Morning. Good morning, madam.
Morning, Doctor.
Thank you
Morning,
for
Shantha,
blessing our CME, ma'am. Thank you very much. This is the start of our glaucoma activities.
It's my pleasure, sir.
Thank you very much, ma'am.
Good morning and thank you.
Welcome, ma'am. Welcome.
With this, we come to the conclusion of the inaugural function. We now move on to the scientific session.
Bindu, you can take over.
Our opening session, as its title describes, will discuss the clinical optic disc evaluation and how imaging complements it. This session will be headed by Dr. Bindu Ajith, who is presently working as a senior phacosurgeon and the head of glaucoma, Contrast Eye Hospital, Kozhikode. She completed her undergraduate and postgraduate studies at Calicut Medical College, followed by her glaucoma fellowship from Coimbatore Aravind Eye Hospital. She is a member of Glaucoma Society of India, World Glaucoma Association, and Asia Pacific Glaucoma Society. She has presented extensively at national and international conferences. She is an acclaimed phaco trainer and DNB trainer, conducting high-volume phaco and trab surgeries. I warmly welcome you, ma'am, to take over the session.
Thank you. Good morning, everyone. Thank you, Ksos, and thank you, Kasaragod Ophthalmic Society, for involving me in this. Now, as we start our first session on diagnostics, evaluation of the optic disc and how diagnostics and the imaging helps us. And for the keynote address, we have Dr. Shantha, ma'am. Can I share the screen? I'm not able to share the screen actually.
Gopal,
What is it showing, madam?
Yes.
Bindu co-host for her to share or what?
Everybody can share. I'll change.
Bindu ille.
In the Kozhikode Ophthalmic Society. Okay. Sir,
only the host can do. Ankit, Ankit?
But she should be able to share.
No, she should be able to share because Stephanie was able to share.
Okay.
She should be able to share. Your side, Bindu, you share once again.
Bindu did the share and patanda, Bindu. Because
okay, then I'll just continue.
Just read.
You can try sharing.
Just try pressing Alt and S, ma'am. Alt and S.
Alt and S. Yeah, did that.
Madam, retry share screen on the child.
I think I'll.
That's okay, Bindu. You can read out.
Okay. Dr. Shantha ma'am obtained her MBBS from Stanley Medical College, Madras, and she went to get a diploma in ophthalmology at Joseph's Eye Hospital, Trichinapalli. And she also has many trainings from the US and she is a great academic achiever with a gold medal for obstetrics and gynecology. It started from there, and then with the best paper award for the paper on ocular manifestation for PAIDS, and the best paper for hypotony in primary trabeculectomy and adjunctive antimetabolites. And then she had the best research paper for the risk of loss of central vision following glaucoma filtration. It's great to have you, ma'am. Over to you for the keynote address.
Thank you. I'm sorry, there's some problem with my...
It is starting, ma'am.
Is my screen visible?
Yes, ma'am.
Yes, ma'am. You can see your screen, but I think you should move to the presentation.
Fine.
Is the presentation visible?
No, presentation is not visible. I think your screen is visible. We can see the window in which the Zoom is there.
Shall I try again? Now?
Yes, ma'am. We can see your presentation. Please make it full screen. And now we can see.
Yeah, just a minute. Is it okay?
Yes, Shantha, that's
yes,
fine.
Perfect. Perfect.
So thank you so much for giving me this opportunity to participate in your meeting. I will start off with the clinical optic disc evaluation and how optic disc imaging complements it. We all know that open-angle glaucoma is a chronic progressive optic neuropathy with characteristic optic nerve head changes associated with corresponding visual field defects, with intraocular pressure being one of the primary risk factors for progression, which is amenable to treatment. There is a gross underdiagnosis of this condition in India, and you can see that the various population-based studies reported have shown that the underestimation is more than 90% of the population examined. One of the factors is the absence of a good screening test. And you can see here that over intraocular pressure measurement, optic disc evaluation and disc photographs score much better in the use of a screening test. It is important to screen every patient who comes into your office by doing a complete comprehensive eye examination, of which optic disc evaluation is one of the most important. So evaluate all optic discs for glaucoma. Recognize that there's a wide variation in normal, differentiate glaucomatous from non-glaucomatous, and correlate it with visual fields. We need to use a biomicroscopic examination with a 90, 78D, or 60D indirect lenses. Dr. Jonas has nicely described the variables that we need to for optic disc evaluation. And this starts with the optic disc shape, the neuroretinal rim size, the neuroretinal rim shape, the optic cup size in relation to the optic disc size, parapapillary atrophy, optic disc hemorrhages, and retinal nerve fiber layer visibility. I'll go through these one by one. So you can see here that there's a really wide variation in the optic disc size. A 7-fold variation has been described. This is a small disc, the average, and a large disc. Overestimation of cupping can happen in large discs and underestimations in small discs. The discs are slightly larger in males, and the size is also based on race, with the African population having the largest disc size, and as we all know, larger in myopic eyes as well. The optic disc shape is also highly variable. The most common is the vertically oval one, as seen here, but you can get abnormal variations which are not necessarily pathological. We often mistake the cup disc ratio as the area of pallor, which is not right. You have to look at the contour of the disc and look at the area where the vessels escape from the disc margin, and that would be the cup disc ratio, which is usually described as a vertical cup disc ratio. So this is a large disc with a large physiological cup. You can see that the neuroretinal rim is normal and the nerve fiber layer is healthy. So contrast this with the large disc in which you have some rim thinning inferiorly and superiorly associated with nerve fiber layer defects. Disc size asymmetry is important to recognize because cup disc asymmetry of more than 0.2 is said to be diagnostic of glaucoma. But you have to correct for disc size. This patient had been referred to us as a person with glaucoma, but actually the asymmetry is due to a larger disc in the right eye and a smaller disc in the left eye. So it's important to realize that you have to correct for cup disc size asymmetry when you look at an asymmetry in the cup size. So contrast this with this patient who's myopic disc with the right eye having glaucomatous cupping and the left eye showing a fairly healthy disc with perhaps an early superior notch. You have heard of the isn't rule, where usually in a vertically oval disc, the inferior rim is larger than the superior rim, which is larger than the nasal rim, which is larger than the temporal rim. And this is usually followed in about 85% of normal discs. But you can have exception to this rule. For example, in the Chennai glaucoma study, where we evaluated the parameters of the healthy optic disc, we found that this rule is not followed in about 8 to 13% of the normal population. So this doesn't always hold good. So when we evaluate the disc, the first thing we look at is the rim changes. You can see here that there's a notch in the inferior rim, which is associated with nerve fiber layer defect extending inferiorly. Similarly, in this disc, you can see there is a large disc with a large cup. You can see the inferior rim thinning extending right up to the disc edge associated with the nerve fiber layer defect and a superior notch as well with a superior nerve fiber layer defect. Disc hemorrhages is said to be 99% specific for glaucoma, and they can be obvious as seen here or subtle as seen here. They're a risk factor for progression for glaucoma as described by the early manifest glaucoma treatment study, the normal tension glaucoma study, and the OHDS. Disc hemorrhages are often associated with female gender and systemic illnesses as well. Very rarely you see it in the posterior vitreous detachment, but once you see a disc hemorrhage, make sure that whether glaucoma is present or not, after ruling out all other causes. Parapapillary atrophy, the importance of this sign was first pointed out by Jonas et al. This is a normal parapapillary atrophy in the temporal area of the disc, which we are all familiar with. It has an outer area or an alpha area, which consists of atrophy of the retinal pigment epithelium, and an inner area or the beta layer, which has exposure of the Bayer sclera and the larger choroidal vessels, more prominent here. Beta parapapillary atrophy is especially associated with optic nerve damage due to glaucoma and due to its risk factor for progression as well. You can see here that this patient has an inferior notch with inferior parapapillary atrophy, which is a typical sign. This kind of moth-eaten appearance is also common, especially in the elderly. You can see that there's superior and inferior cupping, the shallow cup with thinning and extensive peripapillary atrophy, which extends all around. An acquired optic nerve pit has been described. You can see that there's a large pit here and a pit here. Lamina cribrosa is exposed. You have to differentiate this from a congenital optic nerve pit, which is usually pigmented and can be associated with the neurosensory detachment in the macula. Nerve fiber layer defects are very, very important to evaluate. It's best to examine any eye with clear media for the optic disc features as well as the nerve fiber layer defects so that you don't miss subtle changes as seen here, which is better seen in red-free photograph. And you can see this on the red-free illumination on your slit lamp as well. So this is the healthy right eye of another patient. You can see that the left eye, there are subtle nerve fiber layer defects with the disc hemorrhage, with a more prominently seen in the red-free photograph. The changes in the rim can be quite subtle. You can see here that this disc apparently follows the isn't rule. The inferior rim is thicker than the superior rim, but you can see that there's a nerve fiber layer defect here, which is corresponding with the inferior field defect on perimetry. So it's important to look for nerve fiber layer defects, even when the disc appears apparently healthy. Myopic discs are difficult to evaluate for glaucoma. They have large, shallow cups as seen here, extensive areas of peripapillary atrophy, abnormal shapes. The field changes can reflect myopic fundus changes, which have to be differentiated from glaucomatous changes. So this disc is fairly healthy. Contrast this with this myopic disc, which has a large cup with inferior rim thinning and pallor. Various appearances have been described for the disc in normal tension glaucoma. This is supposed to be a focal ischemic disc. This is a myopic glaucomatous disc. This is a sclerotic appearance of the optic disc, which is said to be differentiated from high tension glaucoma, where you get a generalized enlargement of the cup. This was described by Gayson et al., but there is a lot of overlap between normal tension and high tension glaucoma, as we know. So this is of academic interest. We have to differentiate glaucomatous cupping from congenital anomalies as seen here. This is coloboma of the optic disc, optic nerve hypoplasia, and optic nerve pit, which is pigmented as seen here, the morning glory syndrome, and a tilted optic disc. Non-glaucomatous cupping has to be differentiated as well. And here you get pallor more than cupping, as you can see in this case of toxic optic neuropathy, methanol poisoning, and sectoral pallor in NAAION. When do we consider imaging in optic disc cupping? When you have vertically aligned field effects, pallor of the rim more than cupping, other signs and symptoms of neurological problems, an RAPD which develops rapidly, young patients, when there's a progressive loss of vision, which is rare in glaucoma until end-stage disease, and when there's asymmetrical color vision loss. This was a case reported by Dr. Chowdhury from our center in the IJO. This was a patient who had a fairly normal looking right eye disc, but cupping and pallor in the left eye. This was his fields in 2003, and he had been started on medical treatment for glaucoma elsewhere. When he reported to us in 2008, the vision in the left eye had been lost, and this was a temporal vertically aligned field defect in the right eye. Sure enough, imaging showed a suprasellar lesion. So it's important to recognize these signs. So how do we complement our clinical disc evaluation with optical coherence tomography, and do we really need to do it? Structural changes precede functional loss. Therefore, early detection is necessary, and quantitative imaging may be more sensitive and objective than clinical assessment. So we know that low coherence interferometry is the principle of OCT, and you get a non-invasive technique to get high resolution images. So the principle is that a beam of light is scanned across a tissue sample. The reflected light is measured in time of flight delay. As you can see, the time of flight delay will vary according to the depth of the tissue being imaged. We now use a 4th generation OCT, which is the SD-OCT, which measures all light echoes from different delays simultaneously. It has very good axial resolution because the scan rate is huge, from 40,000 axial measurements to almost 70,000. It uses a light source, which is 840 nanometers. The detector is the spectrometers, 75 times faster than the TD-OCT. So this is the SD-OCT, which I'm going to describe now. The indications are baseline examination for ocular hypertension, glaucoma suspects, and early and moderate glaucoma. These are the layers which are seen on the SD-OCT. We need to pay attention to the superficial layers, the internal limiting membrane, the RNFL, the ganglion cell layer, and the inner pexiform layer. Image acquisition has to be similar during each time the imaging is done. You have a minimal pupillary size of 2 millimeters. Same conditions need to be present. Select the optic disc protocol, which is an optic disc cube, 6 into 6 to 2 millimeters. You have a macular protocol as well. The image quality has to be good and well-centered. This is the optic disc protocol, which is centered in the center of the optic disc. This is the macular protocol, which is centered on the fovea. So you have to have a sharp and clear focus, and vessels have to be clearly visible and not broken. No dark corners, minimal saccades. The color intensity should be same throughout, and the signal strength, which is different in different instruments. In the Zeiss OCT, should be more than 7. The measurements are false color coded. The thickest measurements are white. 90% of the measurements, which fall between 5 to 95%, are green. The thinnest 5% are yellow, and the thinnest 1% is red. And the same thing goes for the optic nerve head parameters as well. So this is the deviation map, which you see first. This is the circle of measurement, which is projected about 3.4 millimeters from the disc margin. The disc edge is identified by the edge of the Brooks membrane, which is the black dot here. And the cup edge is delineated by red marks. The neural retinal rim is the area measured between these two. And the cup measurements are taken as the area below this. This circle is extended in the form of a Tisnet graph, as you can see here, with temporal, superior, nasal, inferior, and temporal again. So this is a deviation map where the retinal thickness is compared with an age-related normal. And this is the right eye and this is the left eye in the Tisnet graph. You can, the green area is where 95% confidence limits of the measurements are depicted. Yellow is borderline and red is outside normal limits. So the thickness measurements are also compared in quadrant-wise and clockwise. You can see the circular tomogram here, which can give you a rough idea whether the segmentation algorithm is correct or not. The whole thing is compared to a normative database. So it's important to know what your normative database is composed of. You have 16 pixels, which are combined into super pixels, totally about 50 into 50, which analyze about 2,500 pixels in each optic nerve head being scanned. The normative database consists of 284 normals, 18 to 84, out of which Indians form a small proportion. The axial length of these eyes vary from 20 to 28. The diffractive error is as seen here. The macular OCT is now being used more frequently than we did before. The hallmark of glaucoma is the loss of retinal ganglion cells, and 50% of these lie in the macular region they're about 7 layer thick. So macular ganglion cell loss has been reported in early glaucoma, in experimental glaucoma as well. And recent evidence shows that this early glaucoma can be detected by measuring the ganglion cell complex, which in the serous OCT comprises the ganglion cell layer and the inner plexum layer. This is the macular OCT. This is the thickness map. This is the deviation map, similar to the RNFL. This is the comparison with the normative database. And this is the profile of the B scan, showing the outer limit and the inner limit of the ganglion cell complex. The normative database now has been extended to improve the composition of the Asian population, and now Indians represent about 12% of this database. Again, we need to know the limits of the database, with the disk area varying from 1.5 to 3.14. So anything outside this database may show out as outside normal limits. These are the factors which influence the RNFL and GCC measurements: increasing age, gender, increasing axial length in myopic eyes, which could be due to a magnification error, and race, it is thinnest in Africans. How do we read the printout? You look at signal strength, the image should be well centered, no motion artifacts. Look at the RNFL and deviation maps, the sectoral quadrantic maps, and see that the topography B-scan image is accurately placed. So you start off with the signal strength, which reads 7 out of 10 here, which is adequate. The thickness map is uniformly illuminated as seen here. You don't have any breaks in the blood vessels. The scan is well centered. You get the average measurements here. The RNF asymmetry refers to the asymmetry between the right and left eye, 41% here because of abnormality in the left eye. You can see inferior thinning of the nerve fiber layer here, which shows in this Tisnet graph with dipping in the inferior quadrant into the outside normal range, which is reflected in the quadrant map as well as the clock arm map. And if you look at the segmentation here, you see that there is thinning in the B-scan tomograph as well. So this is an example. This is a patient who has a normal right eye. You can see the parameters here are more or less normal, but there is an asymmetry because there are changes in the left eye. You can see the disc hemorrhage here with nerve fiber layer thinning, which is reflected here as well in the deviation map. You can see it dipping down here in the superior Tisnet graph, and it's being highlighted in the clock arm map. The macular OCT in the same patient, please recognize the horizontal raphe, which is shown in the thickness map. And this is reflected in the measurements, which shows thinning in this quadrant. So the advantages of the macular OCT along with what I had mentioned earlier, is that it is detected early in the disease process. There is less variability in the absence of retinal pathology, less interference from retinal and optic nerve head vasculature, parapapillary atrophy, and variable placement of the measurement circle. And many of these are pre-perimetric. This is a patient I had described earlier, and you can see that perimetry does not show any defects, which highlights the role of imaging. So pre-perimetric parameters have showed 35% sensitivity at 95% specificity in detecting abnormal values 4 years prior to visual field defects. So in these patients, it is important to do serial optic nerve head imaging to identify progression before a defect appears on perimetry. Why do yellow and red regions appear in OCTs of normal patients? 2,500 pixels are imaged for each patient. Therefore, 125 will statistically appear outside normal limits. Also, the examined patient may have parameters which lie outside the normative database, which doesn't mean that this is pathological. Tilted disc, abnormal disc shapes, split nerve fiber layer bundles all contribute to abnormal values. And there's a wide range of the nerve fiber layer thickness in the population, as seen here. The factors which affect scan quality can also result in abnormal images which may not be pathological. Media haze, pupillary dilation, increasing age, increasing glaucomatous damage, and refractive error. So this is a patient with false positive. You can see that though the signal strength is adequate, there's a lot of noise because there is a tessellated fundus with poor reflectivity. And this results in abnormal findings in the patient who is essentially normal and symmetrical optic discs. Contrast this with this patient I had already shown earlier with a subtle nerve fiber layer defect. When compared with the normative database with a thickness was slightly above normal limits, which hides the inferior nerve fiber layer thinking that you see here. But however, with the macular OCT, you can see that the horizontal raphe has been picked up with the thickness map, which shows thinning in the deviation map. So again, highlighting the fact that macular OCT may show defects before RNFL thinning is visible. The problem with the OCT is that in advanced glaucoma, it may not be helpful because incremental changes cannot be detected because of the floor effect. Once progressive thinning occurs, it is a glial tissue which shows a remnant thickness, and this is around 43 to 60. So further incremental change cannot be picked up in advanced glaucoma, and so may not be useful in following up a patient. We need to know what the artifacts are. These could be related to patient head tilt, microsaccades, blink effect, image acquisition dependent because of poor image quality, improper placement of the measurement circle, eye disease related, incorrect boundaries due to retinal pathology, and red disease, OCT showing thinning and absence of clinical change. This is a blink artifact, as you can see here, more obvious in the right eye and subtle in the left eye. So very poor deviation maps, lot of abnormalities in the comparative pictures also here. And similar changes in the left eye, the poor signal strength. You can see that the thickness map itself shows abnormalities. And so you can discard this OCT altogether and repeat the imaging another day. This is an edge artifact produced by parapapillary atrophy, which is more significant here. The measurement circle abuts the area of the parapapillary atrophy, and this will show abnormal areas, which may not be pathological. Contrast this with this patient who doesn't have any parapapillary atrophy and show the delineation in all the parameters is good. This is a media problem with significant lens haze, may not make much of a difference, may produce very subtle defects, but with obvious motion artifacts and significant media haze problem, you can get very abnormal findings. So there is no point in doing an OCT in a patient who has a significant cataract, especially a PSC or an ASC. So poor fixation with motion artifacts, you can get the whole thing being displaced superiorly. You can see this tomograph is very close to the superior edge, which shows that it has been decentered. The disc itself has been decentered to the right. So this again is outside normal limits because of a poor scanning. You can also have problems with poor reflectivity producing a lot of noise, especially in tessellated fundus with extensive parapapillary atrophy. So this again cannot be compared with the normative database, but you can use it as a baseline for follow-up. These are the patient characteristics described by this article in AGO, which is good reading, gives you a lot of information. You can see that a posterior vitreous detachment here has caused the signal to overestimate the retinal nerve hyperlayer thickness in this area. Poor segmentation. This is the poor segmentation. Actually, the line should come somewhere here. So this is showing dipping into the outside normal limits when it is not actually accurate. Such areas you might have to do a manual segmentation. And this is a decentered scan showing abnormal findings. Similarly, you can get absent signal over a vessel. Part of the scan is missing here in the decentered image, and this is a motion artifact. Again, posterior vitreous detachment can show abnormal signals, so you have to correct for this. Parapapillary atrophy, as I had described earlier. Posterior cephalomas and medillated nerve fibers can produce artifacts as well. So this is a scan in which you have a decentration. So this is showing abnormal values. The whole thing has moved upward and it's not well centered, showing again a lot of abnormal values in the comparison maps. Once this scan is improved with manual placement, you can see that the parameters are much better, it's better centered, and the values are more accurate. The macular OCT is a problem when there's a retinal pathology. You can see that there are chorioretinal folds here giving rise to abnormal images, which rule out using this for reading a macular OCT in glaucoma. And the same thing goes for cystoid macular edema and diabetic eyes. This cannot be used. So these are various examples. This is a patient with very subtle nerve fiber layer defect in the right eye inferiorly and a more obvious defect in the left eye. This was the imaging. You can see that these subtle defects are picked up with the OCT, and the more obvious defects are seen in the left eye. Both eyes are abnormal, as you can see in these parameters here, and they're approaching the borderline and outside normal limits. The macular OCT also shows this horizontal raphe here with the significant asymmetry across the vertical meridian. With the spectralis OCT, you actually have an algorithm to look at the comparison of the superior and inferior parameters, which gives you an index whether it is abnormal or not. This patient's visual fields were more or less normal. So again, shows that pre-perimetric glaucoma can be picked up with optic nerve head evaluation and OCT. Now, it is important to recognize that this is a very large disc. So you can see that the disc area is 5.52 and 4.83, obviously outside the normative database. So you can not compare it with the normative database. However, you can use it for a baseline examination and for follow-up. So this was the visual field defect in the right eye and the defect in the left eye. So imaging can be used for follow-up here. Do the different STOCTs which are available in the market have a good agreement? So this was a study done by Medeiros et al. You can see that all the measurements are quite different across the three machines. Therefore, they are not interchangeable. So they found that the RNFL thickness measurements are not compatible, which is attributable to differences in the detection algorithms. So the test should not be used in isolation. The sensitivity of the test will increase with increasing level of damage until it reaches a moderate to advanced stage, after which it can no longer be used. Good quality tests only to be used, artifacts to be identified, explanation for unexpected red areas or green areas to be sought, and beware of false negatives. So imaging should not be used to differentiate normal from glaucomatous. It should be used to differentiate normal from abnormal and then confirm that the abnormal is pathological. It can be used as a baseline for assessment of progression until it reaches a moderate or advanced stage, after which perimetry needs to be used. Experience is required in detecting artifacts or abnormalities. Remember that not all that is red is diseased and all that is green is normal. Thank you.
Thank you, ma'am. That was an excellent talk, reinforcing on the fact that clinical examination is the most important though we have advanced technology, it helps you, but then again, it is also more confusing. Thank you, ma'am. So please join us for the panel discussion along with Dr. Manju from Giridhar Eye Hospital, Dr. Ranjini from Medical College, Calicut, and Dr. John. Dr. Sujit, can you just please share the slides? Yeah, I think I can do it now. Okay, now we'll go to the first case.
Madam, shall I share the screen or are you doing it?
I think now I'm able to do it. Okay. Is my screen visible now?
Yeah, its screen is visible, not the PowerPoint.
Yeah, yeah.
Yeah, it's coming up.
Yeah. Yeah, I think it's clear now. So this was a myopic patient, and the disc was like this. And then this was the OCT picture with lot of, like Madam said, the signal strength was too weak. And what abnormal was that is he also had a sluggish pupil in the right eye. And his pressures were borderline 20, 22, not very high also. So, Madam, will you please comment on this disc?
Yeah, this is a disc with abnormal shape, as is obvious. You can see extensive peripapillary atrophy. This may be a photograph artifact. There is inferior rim thinning here. There's a slope here, which may be pathological. The nerve fiber layer is not really picked out because of the tessellated fundus. What I would say is that in a lot of myopic discs, if the disc is pink, it's more likely to be healthy. But when you have a cutoff here like this, where the rim is approaching the temporal margin abruptly, as seen here, it's more likely to be pathological. In these cases, as you saw in the OCT, this has artifacts, obvious artifacts. So I don't think you can use the OCT. You may have to repeat it. Quite often, the OCT is done at the end of a clinical examination. Tonometry, gonioscopy has been done. So it's perhaps better to do it another day. You can use lubricants to moisture the ocular surface so that the patient doesn't blink too much. With such an abnormal myopic disc, it's better to get all the baseline parameters, an optic disc photograph, baseline OCT with the good scan quality and visual fields, and use that for follow-up.
Okay, ma'am. So the fields and see for if the field is progressing. So it depends more on progress rather than starting on treatment. Is the basic point which you want to express to the audience. Am I correct, ma'am?
Yeah, I'd just like to point out one more thing. This is an advanced glaucoma. So using OCT for progression may not be advisable. Having said that, many patients are very uncomfortable with perimetry. So a fairly recent study, I think maybe a couple of years back, used imaging in advanced glaucomas, and they found that the macular OCT may be helpful in looking for progression. But this is also only up to a certain point, because further thinning does not show incremental change. So if the patient is not willing to get the fields done, you can use the OCT, the macular OCT, to look for change up to the time when you get a floor effect.
Okay, thank you. Now coming to Manju. Manju, can you just, this is the son of the previous patient. He is also myopic, 26-year-old, And this is the fundus picture. Manju, are you there?
Yeah. Can I have do we have any other investigation report?
Yeah, this is the OCT picture of his.
Yeah, I feel here actually the disc is tilted and maybe the changes are because of the tilted disc also. Compared to the previous picture of disc photo of his father, I think reasonably it's okay. It is not very definitely looking like glaucomatous. Do we have HFA also, ma'am?
Yeah, the HFA is normal.
Yeah, and the IOP is also normal.
IOP is also normal.
So I think for him, we can consider it as a baseline test, as the IOP is also normal. And since his father is having myopia with probably glaucoma, I think he need a closer follow-up. And if we document any progression or repeat, maybe a DVT also will be helpful, and then decide on starting treatment. This looks like more of a myopic change to me.
Thank you. So the take-home message, like Madam reinforced the fact that all red is not disease. C for progression, disc evaluation, and then don't over-treat glaucoma. That is what the trend which we are seeing now also. So that is the take-home message. Now, as we move on to the next case. So this is the fundus. Now, Manju, you can continue with this. This is a patient who was on treatment for angle closure glaucoma. And then we found that the fields were progressing. But then we thought the disease was under control. Do we miss anything in these small discs? That is what I want you to tell the general ophthalmologist. Like large discs and a large cup is very obvious, but in small disc, like can you reiterate the fact?
Yeah, I think there is some RNFL defect.
There is a thinning.
Yeah, so superiorly looks like there is some RNFL defect.
Yeah.
So can you have the field report again, ma'am?
Yeah, this was actually shown to reinforce the fact that the disc evaluation, point by point, looking for the rim and all the NRR rather than the disc cup size is more important, so that you don't miss the advances or the progression of the disease. Now, as we move on to the next case, I think this is already. So, Dr. Ranjini, ma'am, can you just join for the discussion?
Yes, Bindu. Yes.
This is a patient posted for cataract surgery, and a routine NCT showed 30. And the eye to be done, the other eye was pseudophakic. So the next common thing is the trend now is to take an OCT. So what do you comment on this?
So this patient in the OCT, the signal strength is very low. Because of the cataract, the signal strength is low. There may be artifact that this RNFL is thinned out, like report you will be getting. So we cannot rely on this printout of OCT. So there are studies that in a patient with cataract, if you do OCT before cataract surgery and after cataract surgery, the OCT is showing normal after cataract surgery. That means it is just an artifact. There is no structural change as such. So you should see can you please show the disc photograph? Is there a disc photograph?
Yeah.
Yeah. Okay. So in this side, right eye, you can see the media is very clear, and the disc is not suspicious of glaucoma. left eye it is very hazy view. So the OCT is not the modality of investigation of choice for this patient. You must do a gonioscopy, see whether the angles are open or whether it is shallow AC. And if you can dilate and see the disc and there is no need for OCT at all for this patient as a first line investigation. So better to go ahead with cataract surgery. Better to go ahead with cataract surgery and reevaluate and keep it under follow-up if the tension is in high 30s. Okay.
So yeah, thank you, ma'am. That was the take-home message. Just because we have the investigation tool, we need not go in for, in all cases, a simple basic gonioscopy showed that the angles were closed in the left eye. So a simple cataract surgery would have brought down the pressure, or if the cataract was not much, even a PI would have helped. So that was the take-home message from this case. Now, as we move on to the next, Dr. John, a techie person who is into more advances. So like Madam said, even with the advanced instruments, we do have artifacts and we are more confused than with the clinical findings. Now, does artificial intelligence help us in any way? Dr. John?
So artificial intelligence is still in a nascent stage. There are lots of studies, lots of computer engineers working on this. And since lot of this, we have lots of images in ophthalmology, it would really assist us in coming to a diagnosis. Even now, we have to actually rule out all the artifacts in the images we feed into the artificial intelligence system, because it very, very easily gets confused by artifacts. And in fact, there are studies which show that if you give artificial intelligence algorithms images with artifacts, you will get a false output for sure. So that is one thing. But there are other studies which try to look up very subtle features. So instead of just looking at the RNFL thickness, it also looks at things such as a speckle pattern or tissue reflectance, which may not be easily seen by the human eye. So it might be able to pick up some things which the human eye cannot see. So it has to be a combination of a human plus assistance by an AI algorithm, which would probably be in the future. Any comments on that, ma'am?
No, I agree. I think it's in a nascent stage and a lot of work needs to be done before you can use it clinically.
Okay.
Yes, ma'am.
John, there's some newer things coming on laminar cribrosa measurements and OCT. Can you just update us on that?
So you can actually measure that. I unfortunately was not able to get further details on that, ma'am. So you
actually,
can.
I read in a journal where there is some software updation included in the newer OCTs, and then they study the laminar cribrosa depth, laminar cribrosa measurements, and the global shape index is the one which calculate. And then, but the study shows that does not affect, or it doesn't show correlate with the severity. That is what it might be. That is why it stopped at that stage itself. So I was just thinking if you have any more on that.
So this will be possible only on the newer machines which have SSOCT and which will need deeper penetration, and even then it has to have the software enabled for that. So it is not available to most people, and like you said, ma'am, it may not be absolutely correlated also.
So that is all because we now know that OCT helps you in early picking up of the cases. Now we want to see where in advanced disease, like Madam was talking about the advanced disease, is OCT of any help to us? Is the question.
As ma'am has said, in advanced disease, the OCT has the floor effect and we do not see the progression. But visual fields is a very complicated test for people to do. So there might be some cases where you feel that visual fields may not be reliable at all. we might have to think of some way to use the OCT also. But if we can get a reliable visual fields, that is definitely the way to go in advanced in advanced glaucomas. I think there are newer visual fields coming up which might reduce the patient subjectiveness. So you might be able to avoid all the difficulties of doing the visual fields, maybe make it faster. But right now, visual fields is not very reliable in some patients.
Thank you. Thank you, Shantha ma'am. Thank you, John. Thank you, Manju. And thank you, Ranjini ma'am. So the basic take-home message is the disc evaluation, clinical evaluation is the most important. And then advise test according to it. It's not that you have an OCT, go with OCT for all cases. And always correlate clinically, and in doubtful cases, look for progression. Thank you. Thank you.
There is a question in the chat box by Dr. Mini NL. Does disc hemorrhage always produce field defects, and will it persist?
Shantha ma'am, will you take up this question?
Yeah, disc hemorrhage is usually precedes nerve fiber layer thinning, and has been shown as a sign of progression in glaucoma. In all the glaucoma trials, as I mentioned, the OHG, the NTG study and the EMGTS study, the disc hemorrhage was a sign of that this eye is likely to progress. So having said that, we do occasionally see patients who present with a disc hemorrhage but remain more or less stable on follow-up. That's extremely rare. Once you see a disc hemorrhage, you have to follow this patient closely.
Thank you, ma'am.
Yeah, Dr. Bindu.
Yeah.
Yeah, I'm Dr. Kiran here. I mean, because you were discussing about the lamina cribrosa.
Yeah, I think that study, which is for the journal.
I just wanted to, I'm not really, I've just read a couple of articles regarding that. And in fact, part of it will be discussed in our one of the journal clubs, which we are having in the next couple of days. So I'm not sure exactly about the kind of software that is used, but certainly there is a software which is called the Morphology One software or something like that. That is used to enhance the optic nerve images that have already been obtained. This is specific to spectralis. I don't know how it is with respect to the Cyrus OCTs. But then you can actually get certain values and get an idea regarding the particular morphological characteristics of the lamina cribrosa. For example, you can express the curvature, right? So if you have a negative value, that would indicate that it is a posteriorly curved lamina cribrosa. And if you have a positive value, it indicates an anteriorly curved lamina cribrosa. And again, there is something called a global shape index. That is also a value that ranges between -1 and +1. So -1 would be a spherical cup. It will basically a spherical cup. 0 would be a symmetrical saddle-shaped lamina cribrosa. And you have a spherical cap, which is again a GSI value of 1. The important thing is that if you look at the minimal number of articles we have, some studies have shown that this is actually correlating with progression. And some studies say there is absolutely no correlation at all. So when it's plus or minus at this point of time, as far as I understand.
Thank you, Kiran, for that information. I think with this, we can finish this session. Thank you, Kasaragod Ophthalmic Society and KSOS for giving us this opportunity. I thank all the participants also. Thank you, Shantha.
Thank you.
Thank you so much.
Thank you so much, Dr. Bindu.
Yeah, you're still sharing your screen, Dr. Bindu.
I think it is stopped now. No.
No, it's still there.
I don't think I'm sharing. I've stopped.
It's some other screen, just showing Dell's screen. You're viewing Dell's screen, not Dr. Bindu's.
I think Dr. Bindu's.
I think it's Dr. Rahim's.
Yeah.
We'll have to call Ankit.
I have sent, okay, that is Dr. Stephanie started screen sharing.
Thank you, Dr. Bindu, and all esteemed panelists for that enlightening session. Now we move on to our second session, Medical Management and its Intricacies. I would like to welcome Dr. Kiran Gopalakrishnan, Senior Consultant, Precise Eye Hospital, Trivandrum, to chair and moderate the session. Dr. Kiran completed his MBBS from Government Medical College, Trivandrum. He earned his MD in Ophthalmology from RP Center, AIMS, New Delhi, from where he graduated with the Best Resident Award. He later worked as a senior resident in glaucoma and cornea in the same institution. He has also worked as a consultant in glaucoma at Vasan Eye Care, Trivandrum. He is a regular faculty in instruction courses in Drishti, AIOS, and Glaucoma Society of India. Over to you, sir.
Thank you, Ksos, the secretary, and the scientific committee. Can somebody change the screen? I'm still viewing Dell's screen. Yeah, it's back. I think we are slightly early. So can we start the session anyway?
Yes, Kiran, start. You may start.
Okay. All right. So we will, in this session, basically discuss about the intricacies in the medical management of glaucoma. If you consider the various spectrum of glaucoma management, medical management, laser procedures and surgeries, medical management still predominates. And with the availability of a lot of medications since 1998, there has been evidence that possibly the number of filtration surgeries have been reducing, which we have also seen to a large extent. I will first introduce our keynote speaker, Dr. Rajul Parikh. He's expected to join us slightly late. So in the meantime, I will introduce him and I'll introduce the panel, and we will initiate a discussion and wait for Dr. Rajul Parikh to join. And Dr. Sujit, can you just let me know when Dr. Rajul Parikh joins, because I'll be sharing the screen for the moment.
Okay, Kiran.
All right. So Dr. Rajul Parikh is a very familiar figure in the glaucoma circles of India. Let me make a formal introduction. He is currently a consultant at the Shriji Eye Clinic and Parikh Glaucoma Care Center in Mumbai, and is also a visiting consultant at 3 hospitals in Mumbai, Lilavati, Dr. L.H. Hiranandani, and the Eye Solutions. So he is a CMC Vellorian, did his both diploma and his master's in ophthalmology from CMC Vellore, and has also worked as a guest researcher at the Malmö University Hospital in Lund University in Sweden. Now, he has a lot of achievements to his credit, and received the Thomas Gold Medal for the best outgoing postgraduate student at CMC Vellore. He's also a member of the advisory board of the World Glaucoma Association and a member of the Glaucoma Society Organization Committee, which is a committee under the World Glaucoma Association, and has also received the FDC Award and the Bell Pharma Award of the Maharashtra Ophthalmic Society for his works in pharmacotherapeutics and innovation in glaucoma surgeries. He has a lot of subspecialties. Apart from glaucoma, he's also an expert phacosurgeon, and is an expert in neuro-ophthalmology, and has a lot of experience as well in works in clinical epidemiology. He has a lot of teaching experience as well, has mentored residents, fellows, and DNB students at CMC Vellore, LV Prasad Eye Institute, and the Bombay City Eye Institute. He is also has worked or is working in the editorial board of Indian Journal of Ophthalmology, where he was the section editor for glaucoma, and has also worked in the editorial boards of Maharashtra Ophthalmic Society and the Journal of Current Glaucoma Practice. And as a glaucomatologist and clinical epidemiologist, he has vast surgical experience in complex glaucomas and has been a principal investigator and a co-investigator in multiple clinical trials, has over 50 peer-reviewed articles and book chapters. His CV went into something like 35 pages in the Microsoft Word document. So I have just condensed all of this into a few slides. And let me also introduce our expert panel here with us to discuss. So I welcome Dr. Meena Gopinath Menon, who is the head of glaucoma services at the Shankara Eye Hospital, Bangalore, who will be joining us. And we have Dr. Thomas Arun Varghese, who is a consultant in glaucoma and neuro-ophthalmology at the Dr. Jacobs Eye Hospital, Cochin, and also visiting consultants in Alphonse Eye Hospitals at Pala and Thodupuzha, and St. Joseph's Eye Hospital in Kanjirapalli. And Dr. Meena Nair, senior consultant in glaucoma services at the Chaitanya Eye Hospital and Research Institute in Thiruvananthapuram. As Dr. Rajul Parikh has a lot of commitments because of the start of the Glaucoma Week, he will be joining us. In the meantime, we will initiate a discussion. Can all the panel members switch on their videos as well? Okay, Dr. Thomas Arun Varghese, are you?
Yes, good morning.
All right, good morning. Good morning. So let me initiate the discussion with a very, very basic clinical scenario. You have a garden variety open angle glaucoma, all right? And the pressures are in the range of say 24 or 25. And he has never been treated before. You are making the diagnosis for the first time, a common clinical scenario that we face. So now you have to initiate treatment. What is your first drug of choice and why? And why wouldn't you consider other drugs as the first drug of choice? Dr. Thomas, please.
Thank you. Thank you, Dr. Kiran, and thank you, Ksos, for this opportunity. I would like to ask a few more details. The age of the patient, his occupation, because all this we are considering a treatment which is going to be lifelong.
When I said a garden variety open angle glaucoma, and basically meaning that this is a 50 to 60-year-old patient with a mild glaucoma with 24 to 25 intraocular pressures. I am talking about a garden variety, primary, simple, mild open angle glaucoma.
Thank you, Dr. Kiran. So the factors we have to consider is one is, as Dr. Kiran has quite clearly said, the severity of glaucoma. It's a mild glaucoma. We have obviously done a gonioscopy to make sure it's an open angle. One important factor is to consider the occupation of the patient and how busy the patient is going to be. If affordability is not a factor, I would consider first prostaglandin analog, because most people of that age group are working and busy. That is the most convenient and the most likely that we get a good compliance from the patient. Dr. Kiran.
Yeah. Your prostaglandin would be the first drug of choice, because you would only require it to use once daily. Because it generally produces better intraocular pressures control, both in terms of the highest intraocular pressure as well as in terms of diurnal intraocular pressure control.
Yeah.
Yeah. Dr. Rajul Parikh is calling me, so let me just take his call, please.
Kiran sir has joined actually.
Okay, Dr. Rajul has actually logged in. So, Dr. Rajul, can you switch on your video, please?
Yes, I have.
Yeah, all right, sir. Sir, I have already given a glowing introduction in about as few slides as possible, considering the nature of your huge CV. So we are waiting. You can basically start your keynote speech, and then we will go on to our panel discussion.
Okay. One second. Okay. Visible?
Yes, sir. Your screen is visible to us. Yes.
My voice also clear?
Our voice is clear, sir. Please go ahead.
Okay. So, good morning, everyone. I will be talking about the comprehensive glaucoma, medical management of glaucoma for next 15-20 minutes. So I'll give basically what is my philosophy, and I'll try to cover comprehensive medical management, including the follow-up issues. So the philosophy, we must remember that glaucoma is a non-curable one-way disease, and the objective is to maintain the visual function for the patient's lifespan, and therapy should have minimal effect on the quality of life. So basically, the purpose of treating glaucoma is not to lower the IOP or the optic disc or to visual field. We are preventing blindness, that we must remember. And in that regard, I would like to clarify that the objective is not to lower the IOP that less than 21 or about ages mentioned less than 12. Some ophthalmologists talk about that, or only look into visual field or optic disc or RNFL. We have to have overall picture in mind. Having said that, we must remember that it is the patient who is the center of the management and not one individual parameter. So when we treat, we are treating the patient, not one parameter of that optic disc or IOP or whatever. So having said that, again, I will reiterate, the objective is maintain the visual function for patient's lifespan and therapy with minimal quality of life, effect on the quality of life. That is the most important thing we must remember. So various studies have shown that all the RCTs that IOP lowering is important, and I'm not going to debate about that. So the important thing is IOP lowering helps reducing the progression, lower the IOP, lower the progression, and in early management, better the outcome. But having said that, we must remember that it is individual, applies to every patient, not the general guideline. So, the whole algorithm is based on EGS and APGS guideline, and based on that, we had written an article on IGO. Can you hear me?
We can hear you.
Clearly audible, sir.
Some network issue. Just give me 1 second.
We can hear you. No problem.
Well, 1 second. There's some network issue. I'll just connect it through my hotspot. Just give me. Okay, is it better now?
Yes, sir. You are visible and audible, sir.
So the objective is, the algorithm is based on an article I had written in IGO 2008. So objective of medical treatment is that we know that it's a progressive optic neuropathy without a cure. We have to stabilize the function, and vision must outlast the patient's lifespan. That is the objective. Now, when we treat medical treatment, we have to remember that IOP should be controlled for 24 hours. As minimal medication we can give, no long-term trip, no systemic side effect, preferably very minimal local side effect, and user-friendly. So if I can give once a day, is always better than 3 times a day.
Now, this is the real case which I had seen in 98 when I was doing residency in Vellore. And this is not hodgepodge or my imagination. This is real case. 39-year-old patient had come for second opinion, was diagnosed angle closure glaucoma in 95, 2 years of regular checkup when pressure was 60, was treated with TRAB, other eye was not treated. After 2 years, diagnosed angle closure in other eye, treated with TRAB, and when patient came, patient didn't have any visual field or optic disc finding in the folder what she had. This is the treatment. And again, this is what exactly the treatment what patient was on. 2 different kind of beta blocker, Rizalutan twice a day. And patient had come because patient was advised second surgery. IOP was 14 to 16. Lab was good, no ostium visible, 360-degree close because that is what we expect. This is the first field, of course, didn't correlate. The left eye also didn't correlate. So we repeated and we realized that right eye, it was advanced damage, but most probably one-time vascular event rather than glaucoma damage. But whatever said and done, yes, damage was more. But left eye, the visual field improved. So learning effect. So, this case, and why I'm putting this case again and again, because this case shows us so many things that when you want to treat any chronic disease, including glaucoma, we have to know that only symptom is not important, complete examination. At the same time, when we want to treat glaucoma, we have to know the dosage of medications. We can't, treat the way we feel like. We can't give 2 different kind of molecule of the same group. We can't give prostaglandin twice a day. So those things are very important. So complete examination, we should know the basic of whatever the disease we want to treat. Now, medical management, when do we start? What should be the initial treatment? When do we add or substitute? Which one? And the last 2 questions I will take first was what is maximum medical therapy? And in Indian scenario, the difference between POAG and PACG in relation to the medical management. Now, what is maximum medical therapy? So by definition, it is the minimal number of medication and concentration that provide maximum IOP lowering. That means that if I can control pressure with 1 medication, that's good enough. But lots of patients require multiple molecules. So the textbook, if you look, it says 3, but now we have molecules, 2 molecules combination in 1 bottle. And we have non-beta blocker combination also available. So we can say 4 drugs in 2 bottles, but individualized to every patient. So if patient says I can put only 1 drop in a day, his compliance goes down, adherence goes down. When you increase the number of drops, then that is the maximum for him or her. And POAG, yes, once the iridotomy is done, then the management is more or less similar because prostaglandin works very well even in the 360-degree angle closure. In Indian scenario, we must remember that angle closure glaucoma is very important, and open angle glaucoma is diagnosis of exclusion. That means gonioscopy is must in every patient. Every patient, I'll just give one example. This was 50-year-old female, was diagnosed open angle glaucoma, started on beta blocker, came for second open, and gonioscopy shows multiple synechiae. This is angle closure. The first line of management should have been iridotomy. So the 5 steps of medical management: first, good baseline, good comprehensive examination. I just showed one example that it was missed, angle closure glaucoma. The second, based on patient's finding, we start target IOP, then we start medical management, then we follow up because we want patient to be stable, but we have to look for progression. Any patient progresses, then we modify management. So the first here, the complete examination, including IOP, applanation tonometry, gonioscopy, optic disc RNFL changes, visual field and imaging. That is the most important thing in baseline. This one patient, I just give an example. IOP was 22-21, was advised treatment, but referred for second opinion. It was written glaucoma is coming. Now, if you look at the disc photograph, it's a large disc, but the ISNT rule is followed. So this is basically a physiological cupping and not glaucoma. So we just monitor the patient. And you can see the visual field also is normal. So the must message, a proper baseline examination is very important because that determines your follow-up and management. Now, target pressure is based on multiple criteria: structural damage, functional damage, baseline IOP, multiple pressures, age, and presence of additional risk factor. Because if the patient has multiple systemic risk factor, then patient lifespan reduces, and in that turn, the target pressure also can vary. And in that relation, This EGS graph, this is very important. It gives you very clear-cut idea that how you should base your target pressure. Minimal damage, you go for higher IOP. Short lifespan, you go for higher IOP. As opposed to advanced damage, you go for the lower IOP. If the baseline IOP is low, then you must go for very low IOP. So this is EGS, everybody knows. I'm not going to go in detail, but this is how you based. Now, when it talks about, so the second message, target IOP calculation is important. And you must remember that IOP is a dynamic phenomenon. As the years goes by, the disease can progress or patient's systemic status can change. So it's a dynamic phenomenon you must remember and you must modify as and when necessary. Corneal thickness, I'm not going to again go in great detail. We know that the appellation has problem. The higher the corneal thickness, falls high IOP, lower the corneal thickness, low falls IOP. But we don't use algorithm because there is no agreement. I divide more than 550 is thick, less than 500 is thin. So I know that thinner the cornea, the problem with appellation measurement, as well as with the, there are some studies shows that progression is faster in a thin cornea. So you remember that. So corneal thickness should be the integral part of complete examination of glaucoma patient. Every patient, is more important when you want to treat or not treat ocular hypertension, normal tension, before you want to send patient for systemic evaluation. Now, say first line drug is depend upon the target pressure. The factor to keep in mind, of course, is efficacy, adherence, safety, persistency, and in Indian scenario, affordability. Of course, there are lots of generic available which are cheaper, but still, there are patients who will not able to afford even a generic prostaglandin. So you have to keep that in mind. Having said that, in ideal scenario, prostaglandin is as close to the ideal drug as possible in this today's world because it's once a day, very minimal or negligible systemic side effect, few local side effects. So I would consider as first line drug in most of my patients. Unilateral drug trial, I'm not going to go in detail. I usually like and I do in most of my patients, but I would not force people to do it because people have concern that IOP is high in other eye, what to do. Of course, you can give systemic azathioprine for a few days and stop 72 hours before the next visit, and it will work very well. But if you are not doing it, well, good enough. You don't have to do it all the time. But in my practice, unilateral drug trial plays a very important role, and I usually like to do in most of my patients. I just give one example, and this is not only for the unilateral drug trial, also gives idea that when to add, when to switch. So this is the baseline pressure going up to 33. Inferior node, superior arcuate defect. I started prostaglandin. IOP is reduced by 35%. So I would say it's good enough. Though my target was 16 to 15 to 17, it has gone in that area. I would follow up the patient. I'll start in other eye. If the patient has reduced 20%, in that case, you can add or you can switch because we know that prostaglandin switching the molecule also has can have more IOP lowering ability. So like from latanoprost, you can shift to bimetoprost or travoprost like that. But if there is no impact, then you can change the molecule or you can add. When you say prostaglandin where you are given, adding switching is more important if there is no effect. Otherwise, usually we add. Now, patient I had given beta. The IOP lowering was good, but patient didn't tell me that he is a COPD. He said, I'm fine, I don't have any problem, but I'm not case of COPD. Usually, I would avoid beta blocker in patient with respiratory problem because you know it worsens in the longer run. So I would definitely stop and switch to something else. So this is the APGS guideline. We see whether IOP is achieved, target IOP and no side effect. In that case, we continue. If patient has target IOP achieved, but severe systemic side effect or local side effect, I will change. Partial effect, then we can either add or switch. When we are adding, we add individually, and then we can go into the combination molecule later on. But periodic verification of IOP, visual field, optic disc, and quality of life is very important. That is the most important aspect of glaucoma management. When we start medical management, eyelid closure and purple occlusion is very important. We must explain the patient because it reduces systemic side effect, especially patient who on beta blocker alpha 2 agonist. Now, where we want to follow up the patient to detect the progression. Of course, we want patient to be stable, but it's not possible. So we have to go other way around, and we have to make sure that patient is not progressing. And to detect not progression or progression, we have to follow up the patients. When we follow up the patient, these are the issues to keep in mind. Patient subjective well-being is very important. Ask about the visual function, the risk factor IOP gonioscopy, reassess the structural function on regular interval. If he's progressed, then rate of progression, identify the adverse effect, assess the compliance, and identify changes in current medical. If the systemic medication has been changed, whether it can have impact on his IOP lowering or his glaucoma, that is very important to assess, and quality of life. So IOP every visit, explanation every visits, call the patient different time of the day, every visit, no doubt about it. Gonioscopy does not require every visit. Once a year is more or less adequate. But if there is any change in clinical picture, so IOP suddenly is high, then you must put gonioscope and see what is happening to that patient. So regular follow-up with IOP and gonioscopy is most important aspect. Then comes structural and function changes to look for progression. How? So we have visual field and imaging. How frequently? If you look EGS guideline, it says at least 5-6 field in first 2 years, and then we can go on depending upon slow or low progression, fast progression. Fast progression 6 months, slow progression once a year is more than adequate. So what I follow is at least 4 fields in first 2 years, and then I go once a year because most of the patients are slow progressor. Advanced glaucoma, fast progressor, I will continue doing 6 monthly, perimetry and imaging both. So progression we know is evolution of disease from one stage to another stage. And I'm not talking every progression requires change of management. That requires there is a clinical picture. Also, we have to look into it. But visual field progression, overview, I don't rely on overview. So what I do is guided progression analysis. We have event-based analysis, and this talk is not about that. So we have likely progression, possible progression. The likely progression is the more robust way of identifying progression. But if the patient is possible progression, do the repeat field immediately within a few weeks to make sure that patient is really progressed or not. And then we have a summary of visual field index. It is very nice 10-based analysis and a very good way of looking into the rate of progression and along with event-based progression. So these two things combined gives us a fair idea the visual field status of individual patient. Optic disc, of course, if you have photographed, it's a nice way, but in clinical practice it's very difficult. So we rely more on the imaging. So we have OCT, guided progression analysis. We have HRT. Most of the people have OCT machines. So OCT guided progression analysis is a robust way of correlating along with the perimetry, not in isolation. So what I do in my practice, full clinical picture, IOP, as I mentioned, explanation, I call patient different time of the day. Then I look optic disc every visits. Field, as I mentioned, that more or less once a year after the first 2 years is gone, where I have done at least 4. Imaging also I do in most of my patients, but I do not change management only based on imaging. So if the visual field shows progression, then I will be more suspicious of progression than imaging. Everything has to correlate clinically. So if the patient's precious IOPs are not well controlled to start with, then yes, then even imaging progression gives us a very a reasonable way of saying that yes, we need to change. But if the pressures are stable, absolutely controlled on the target range, then only imaging progression I would know. I'd be suspicious, may call patient early, but imaging is not the only way to look for the progression and definitely not to change the management. So detecting progression early is key, and guided progression analysis, imaging and perimetry gives us a fair idea how to do it. Now adverse event is direct relation with the adherence. So I would definitely look for the systemic and local side effect, because the local side effect also can have direct impact on adherence. Like provided if you, let's say one patient you study uniocular prostaglandin and patient has this increase in eyelashes or redness, he's not going to continue with that. So you have to look for this and change as and when necessary. And quality of life. If you've given a 3 different bottles, 6 times a day drops, which is impacting his work, day-to-day work, then his quality of life is affected. So you have to use this into your armamentarium and modify the management accordingly. So quality of life has direct relation with compliance, and you have to keep that in mind. I want to reduce IOP, we want to have glaucoma stable, but at the same time, we want to give a decent quality of life to that person. And don't forget that. And various studies have shown that adherence is an issue, even putting 1 drop. I'm not going to talk about the percentage, but adherence is an issue, how to detect adherence. Because patient likes to say that I am a good patient. He would never say that I am not putting drops properly. And if you directly ask that your adherence is poor, he will get offended. So identifying adherence is an art, not science. So you have to be very friendly with the patient. What usually I do, I have this 4-step approach. I don't ask direct questions. I say that are you taking medicine? You talk about yourself that taking medicine is an issue. I forget. And it's universal. So take confidence. Then you say that how many times you're putting drop. Then you say how many months the one bottle lasts. Usually that how many days or weeks the bottle should last if he's putting properly. Then ask, are you forgetting? It should be the last question. And if he says missing once a week, then you must assume that it is more than once a week. So detecting adherence is an art, not science. Suggesting the options to take care of adherence is a simple science. Lack of concern, explain the patient that what is glaucoma, again reiterate that it can cause blindness and we can prevent blindness. If the problem is taking the number of drops, then you can reduce combinations. If he's concerned about side effect, then I said most of the local side effect does not have any problem. If he's difficulty in drop administration, then he said that ask related to put, because in India, lots of people stay in joint family, and putting drop by relatives is an easy solution compared to the Western population. So we can suggest that. So adherence, keep in mind, even if the disease is stable, you must remember that. And disease progressing despite normal IOP. So confirm diurnal variation. The nighttime pressure can be high in 40% of the people. Keep that in mind. So we may require nighttime pressure checkup in rare patients. Other side effects like nocturnal hypertension, intermittent use of systemic steroid, recent major history of blood loss, because it can have one-time effect, but the glaucoma would have progressed. If you're not measuring CCT, then corneal thickness. Systemic hypertension, and especially nighttime dips, can have lead to glaucoma progression. Sleep apnea and other habits like patient doing yoga, especially Sirsasana, or rapid consumption of large quantities of water or alcoholic drinks. So these are the factors we have to remember for the progression despite normal daytime office hours IOP. So glaucoma management is a lifetime process. Continuous vigilance is very important. We have to keep this in mind that once you diagnose glaucoma, is just the beginning. Managing glaucoma is a lifetime process, and it should be, as I mentioned, there are multiple parameters we have to keep looking in. Only IOP is not important, as well as only reducing the pressure is not important. We have to see whether it is causing any problem to the patient's quality of life, and all put together, we can manage glaucoma, and most of the time we can make disease stable without much quality of the life. But we have to involve patient in the decision making. It is not our decision to put on the patient. It is patient's input and a combined efforts to take care of glaucoma. That is what we have to do. Thank you.
Thank you, Dr. Rajul, for a very comprehensive presentation. I hope we will continue to be with us for the next 20-25 minutes for the panel discussion also. So let me welcome back the other members of the panel for discussion, Dr. Thomas Arun, Dr. Meena Menon, and Dr. Meena Nair. So, sir, one of the first questions that we asked about...
Dr. Kiran,
yeah.
If you can leave me in 15 minutes, is it okay?
Yeah, that's fine, sir. For the 15 minutes, fine. Yeah, that's fine. So we had initially started with asking the question of what is the first line of drug in glaucoma management, and the general consensus that prostaglandins basically are the best first line drug to initiate a treatment. So Dr. Rajul, are there situations where you wouldn't want to start prostaglandins as the first line drug in a primary glaucoma or other glaucomas as well? And where would you be particularly cautious in starting prostaglandin?
Usually in primary glaucomas, I would start prostaglandin most of the time, unless they say that patient has a recent cataract surgery and had a PC rent. So in those patients, I would be little bit worrying about starting the first line prostaglandin. If the patient had, let's say, definite history of herpetic keratouveitis, in those patients, I would be little worried about starting prostaglandin. I have seen patients where I've restarted after even a 6 month, 1 year of healed keratouveitis, herpetic keratitis, it can recur. So in those rare situations, or if a patient is a known case where the earlier prostaglandin had not worked at all, otherwise, and that is rare, but the non-response can happen, I would be usually start prostaglandin as first line in most of my patients.
Okay, sir. So you had intimated, just told us about the cataract surgery issue. So one of the common scenarios we face is that, you have patients with glaucoma on prostaglandins. So what is your opinion regarding stopping of these drugs prior to cataract surgery? Is there
I don't stop. But if the patient is only one molecule, And we know that IOP, cataract surgery reduces IOP for short term. And if early glaucoma, I would not, I may stop for the time being.
Dr. Meena Menon, do you have any views on stopping prostaglandins for considering the possibility of CME? Do you think that this is a factor?
Dr. Kiran, as Dr. Rajul said, I don't generally stop prostaglandins unless and until there is some clear-cut evidence of diabetic retinopathy with CME or something like that. Otherwise, if an untoward incident occurs during the surgery, like a PCR. Otherwise, in my routine practice during cataract surgery, I don't stop. I continue the prostaglandin. We had done a few patients. We had followed up with OCT, so that it was very evident that even we couldn't find any OCT evident CME also in any of these patients. So in my earlier practice, I was doing that, but then after that, I stopped. Stopping the prostaglandin.
Oh, thanks, madam. In fact, 10 years ago, if you asked a panel, out of 10 people, 7 would have actually stopped. And now it's the other way around. Most people do not stop. I think one of the theories is that the CME that happens in the post-op period is mostly related to the endogenous prostaglandins and not the prostaglandins you actually give exogenously. And therefore, it might not be particularly significant as far as CME is concerned.
Yes.
Okay. Now, one of the panelists, one of the viewers have actually posed a question. This is actually regarding ocular hypertension. So I thought we would probably just have a quick discussion on ocular hypertension. Dr. Meena Nair, what is your basic algorithm for management of ocular hypertension? Of course, we are assuming that this is a clear case of ocular hypertension and we are not in any doubt about the discussion. What are the things that guide you in management of ocular hypertension?
By ocular hypertensive, it makes it very clear that the discs are normal, as you said earlier. So the first concern is the age of the patient. And secondly, is there a relevant family history? If he comes from a family where there's a very strong family history of glaucoma, then of course the high IOP detected on a one-time recording appears to be somewhat significant. But it is very important that you have to correlate it in this scenario with, just like Dr. Rajul Parikh said, with the central corneal thickness, so that you exclude a very thick cornea and you kind of think that you are estimating almost a near normal high intraocular pressure. But I think if the patient is available for a close follow-up, say annually or every 6 months, so that we can have a good evaluation of the patient's optic nerve head and IOP, it is worthwhile following up a patient depending upon the level of the IOP. But if the IOP is above 30 in the first go, despite having a normal corneal thickness, if the IOP is in the range of 30 or 35, I think even the EGS guideline says that you can start treatment.
Okay, so you have basically mentioned about age, the baseline intraocular pressure, and you also mentioned family history, right? So
you have to take a baseline optic disc photograph and an imaging, even though you know it's going to be normal, and document that the field is normal. So basically, if the level of IOP is below 30 and the patient is available for follow-ups, document everything and you can afford to follow up as the patient is what I think.
Dr. Rajul, do you have anything to add on ocular hypertension treatment?
No.
Okay, so I think there's been a lot of data from both the OHTS trials and the EGPS trials, and there is basically a validated risk calculator which is easily obtained for anybody who is listening in the audience. You can easily obtain this validated risk calculator from the OHTS. I think it's available in the American Academy of Ophthalmology. You can simply search it on your search engine. You will get this. So it basically has about 5 parameters. You can input the parameters of your individual patient on this risk calculator. It includes, as Madam mentioned, age. It includes intraocular pressure. It includes central corneal thickness. It includes also the pattern standard deviation of the visual fields. So you input these parameters into the calculator. It will basically give you the risk of that particular patient
developing glaucoma over a period of time. And this calculator has actually been validated across multiple studies as well. The EGPS study, which is the European equivalent of the OHTS study, also actually validated this risk calculator. And this has also been validated in a few other studies. This is something that you can actually make use of. And so another question is regarding, of course, this would be an expected question in a medical management. Rho kinase inhibitors, is it a first-line drug or a second-line drug? Dr. Thomas Arun Verghese.
As of now, Rho kinase, I would probably second or third line drug rather, because one, as you know, one significant side effect is the hyperemia, and also cost factor as well. So usually I start on a prostaglandin analog, and second line, if there are no side effects, probably a beta blocker, sometimes a carbonic anhydrase inhibitor, and then probably as a third line drug, Rho kinase I'm using as of now. And also the cost factor, and to the one of them, as you know, is twice a day, but one is once at night. So that way compliance is good, but hyperemia in some patients is a problem.
Okay, all right. Dr. Meena Menon, do you have anything to add on to your Rho kinase inhibitors, your experience so far?
Yeah, yes, as it's again definitely my third choice or a last choice of drug. We have been seeing few patients with, in fact, I use more of netosudil than ripasudil. So netosudil, I have found probably around 5% cases having honeycomb appearance of cornea. So I am a little skeptical in putting these Rho kinase in my kind of cornea related patients like post PK. I have seen a very clear cut honeycomb in one of my post PK, because post PK again you are little tied up with not being able to use a prostaglandin many a time. So I was very happy to use netosudil, but then unfortunately I see this honeycomb appearance, and pedicle hemorrhages is a factor, which we need to look on all these patients. So there are some issues with these drugs, but then many of the patients, yes, this is a good add-on drug.
All right. Okay. For the audience who just to clarify about honeycombing. In fact, a lot of the Rho kinase inhibitors are currently being used by the cornea specialists because one of the theories is that the Rho kinase inhibitors can basically help in kind of endothelial regeneration and basically suck out the fluid from the deep stroma in cases of corneal edema. And there have been quite a few case reports over the last 6 months or so, mainly in cornea journals, regarding how they have used it for various conditions, including iridocorneal endothelial syndrome, pseudophakic bullous keratopathy. And what has been noticed is that in some percentage of patients, there is an epithelial honeycombing appearance that happens possibly because the fluid from the deeper layers are sucked out into the more superficial layers. In generally, this honeycombing has noted to be present only in those patients with already existing corneal edema, not in patients who have otherwise normal corneas. And generally, this honeycombing is not supposed to have a huge impact on vision per se. And it generally tends to resolve once we stop the netosudil effect. So it does mean that Rho kinase inhibitors has some action in pushing out fluid, and therefore a lot of cataract surgeons now use it in their initial post-op, IOP spikes, because it can kind of reduce the intraocular pressure. At the same time, it can reduce a little bit of corneal edema, and plus they are already on a lot of steroids as part of the post-op regimen, so the hyperemia and all those things actually are not a big issue. So are there any specific scenarios, Dr. Meena Nair, where you would think that where you have found some specific benefit for Rho kinase inhibitors? Because whenever a new drug like Rho kinase inhibitors come, this is a drug that targets the trabecular outflow. So everybody gets excited because you are theoretically going to affect the outflow network that is most important in aqueous drainage. And therefore, you would expect that these drugs are going to work miraculously. But certainly in terms of intraocular pressure lowering efficacy, they have been found to be not as good as prostaglandins and found to be basically non-inferior to timolol and other group of drugs. So are there any specific circumstances, Dr. Meena Nair, where you would think that where you have found some benefit with Rho kinase inhibitors?
Yeah, I would say that definitely it's a good adjuvant drug, just like the previous speakers have told. And I would say when timolol is contraindicated, rather also when prostaglandin is contraindicated, under such situations, probably you would think of the ROCK inhibitors. And have also used more of nitazoxanide than the ripasudil. Actually, I think
yeah, nitazoxanide has the advantage of once daily action, as Dr. Rajul also mentioned, because you are generally using these as adjuvants. The patient is already on drugs they are using at multiple times. So the advantage of having a once daily drug over twice daily drug certainly gives you an advantage. The downside, I suppose, is that it has to be temperature controlled. They have to be preserved in refrigeration, whereas the twice daily ripasudil need not.
May I ask a question, Dr. Kiran?
Yeah, sure.
I wanted to ask the experience of the panel, the brinzolamide brimonidine combination.
Right.
So, because as we know, the combination has got brimonidine 0.2% as opposed to single brimonidine, which is 0.1%. So I have burnt my finger a few times. Few patients were quite happy on brimonidine and brinzolamide separately, and then this new combination came, and I switched them to the combination, and they had quite serious systemic side effects. I mean, hypotension, the side effects that were caused due to high strength brimonidine. So I wanted your experience on that.
Okay, okay, let me just answer that first, and we'll go to the other panel. Okay, so if you take brimonidine alone as a compound, we know that we started with 0.2% brimonidine as the initial drug. When it actually came to the market, it was 0.2%, and all the trials looked at using it 3 times daily. And what we found with the initial trials was a very huge percentage of non-adherence because of basically local effects, basically in the form of allergic conjunctivitis. And this is not a very small number we are talking about. Studies have reported almost 33-35%, and that's like 1 in 3 eyes basically having huge local side effects with brimonidine. And then they have basically tried to reduce the concentrations from 0.2 to 0.15 and 0.1, right? And with the lower concentrations, yes, the side effects did tend to come down, especially the side effects in the initial phases. But what we need to understand with brimonidine is that brimonidine not only produces an immediate allergic reaction, but it can present with delayed hypersensitivity, the type 4 kind of hypersensitivity. And this is probably specific to the compound itself rather than the concentration. And therefore, what would happen in patients with even lower concentrations of brimonidine is that for 9 months to 15 months, I think there have been case reports of delayed hypersensitivity developing even after 15 months. And they will, and it is something that we might completely miss as a clinician because they have been using it for more than a year, and suddenly they are coming with allergy, and we are now thinking of external allergic factors and not thinking about brimonidine. So brimonidine is a notorious drug, not only in terms of concentration, but as in terms of its the molecule itself, it can produce delayed hypersensitivity. So when brinzolamide brimonidine came up and it had this 0.2% concentration, I was completely expecting that this kind of allergic reactions might happen. And that has been my experience as well. And therefore, it is really, I mean, the only reason why I use brinzolamide brimonidine combination is when I can't use timolol as a combination because of systemic side effects. But otherwise, this is a big problem. And while you start a patient on this drug over a period of time, most of them do develop allergic issues, but I'm not particularly aware of systemic side effects like hypertension that you mentioned with regard to this. Dr. Meena Menon, do you have any comments?
Dr. Kiran.
Yeah, do you have any
systemic side effects? Yeah.
Right. Madam, do you have any comments on this combination? Because
no, like I've not had really an experience about the systemic side effects as such. Yes, delayed hypersensitivity is a known thing, but personally, I've been quite happy with this combination. See, most of the time I put this combination in patients who have most of the secondary glaucomas, post retina surgery or post retina issues. I find this combination very good. But yes, as Dr. Thomas said, like sometimes when there is a delayed hypersensitivity, I have switched back to kind of individual drug because I can put brimonidine 3 times. And there are times that it helps. Like, you increase brimonidine to 3 times, and in fact, brinzolamide also, sometimes you put 3 times or 2 times if the patient is compliant enough to put these dosages. I have rarely switched back to such situations, especially when I don't have a choice, like in a post-secondary, in case of post-retina surgeries, glaucomas and all that. But personally, no, systemic side effects have not really had much of an issue. Probably I should look for it now.
Okay. Dr. Meena Nair, I mean, brimonidine basically came into the market and basically had a huge hold on people after the publication of the LOGS trial, where the low pressure glaucoma treatment trial, when they compared brimonidine with timolol and found that possibly there is a neuroprotective effect for brimonidine, and still people talk about a neuroprotective effect for brimonidine. What is your opinion regarding that?
Yeah, all of us in practice, I think, are implementing the Loget's theory. Like you said, that they put brimonidine. I do use it for that context, but of course, watch out for the early as well as delayed follicular conjunctivitis and blepharoconjunctivitis issues. There are lots of people who use dorzolamide also in such scenarios, though its purpose is to improve the ocular blood flow and not exactly neuroprotection. But these two are being used. But I don't think that one totally has faith that that is going to take care of the glaucoma.
Okay, actually, with the LOGS trial did actually show that there was some protective effect of brimonidine compared to timolol, because in both the arms the intraocular pressures were same, but visual fields were better preserved in the brimonidine arm, and hence the argument was that since the intraocular pressure between the two arms were the same, there has to be a non-IOP factor there and possibly a neuroprotective effect. And neuroprotective effect has actually been otherwise demonstrated in animal models, in crush injury models and other cell culture models with brimonidine. But one of the important points again with respect to brimonidine in the LOGS trial was nearly that 20% of the people actually dropped out of the study in the brimonidine arm because of allergies, and that it seems it's a problem when you look at the final statistical analysis. I think there was a reply that was given by the LV Prasad colleagues when the LOGS trial was published regarding the fact that if you assumed that all the 20% who dropped out of the brimonidine arm were the ones who also underwent some progression of visual fields, because you don't have the data of those people, right? 20% dropped out. Of course, it would be a stretch to imagine that all of them had progression of visual fields. But if you put that into consideration, then there is no difference between timolol and brimonidine arms, and in which case the LOGS trial result would not actually hold true. So coming on to this, Dr. Thomas Arun Varghese, you have a diagnosed NTG. What is your first drug of choice?
So definitely NTG, I want to avoid beta blockers. So again, check the corneal thickness. I would go for a prostaglandin analog, because that again will give a good drop in IOP and can get a good compliance as well.
Yeah, I suppose. Yeah, Dr. Meena, please.
I probably prefer an alpha agonist in an NTG generally. Okay. So
and that is because of
both ways, neuroprotective action, and because you have the central fields which are a little deeper in case of NTGs. So I prefer to give an alpha agonist, but yes, again, depending upon the compliance issue, if the patient is not very willing to put 2 times a day, I will still prefer a prostaglandin, but probably my first choice will go for an alpha agonist.
Okay, neuroprotection is an interesting topic, because some people do argue that the best neuroprotection still is intraocular pressure lowering, in which case prostaglandin still rule the roost. Okay, Dr. Meena Nair also mentioned about this ocular blood flow, right? And this is something that a lot of clinicians are, thinking about. So, what is your opinion? Do you think that the carbonic anhydrase inhibitors do have an impact on ocular blood flow? What is your opinion? Dr. Meena Nair, please.
Yeah, I do think dorzolamide does have has a role in improving the ocular blood flow.
Right.
So,
do you think that this improvement in ocular blood flow does translate into some benefit in terms of preventing more functional impairment?
No, I think you have to narrow down and select the patients that you want to give it on. because people who have a decreased optic nerve head perfusion, especially like always it's mentioned about those who are on antihypertensives, those who are in favor of a nocturnal dip, and rather those who have a very low diastolic BP, because the mean ocular perfusion pressure, if it is low, definitely it is a risk factor for the progression of primary open angle glaucoma, NTG, etc. So for the mean ocular perfusion pressure, the diastolic blood pressure has a very important role. And I would say a nocturnal dip and a diastolic BP less than 55 to 60, they are the people who may benefit. So hypertensives, those who are on antihypertensive medications, I think it's a good, worthwhile considering the addition of dorzolamide.
Okay, madam. Actually, so for the benefit of the audience again, if you look at meta-analysis of drugs on ocular blood flow, so this has been looked at in quite a bit of detail. So, all the studies published on ocular blood flow, 72% of the studies, 72% of the studies show that ocular blood flow is increased with dorzolamide. So dorzolamide, I mean, there is some evidence that the ocular blood flow is certainly increased with the use of dorzolamide. And with the meta-analysis with brinzolamide, they didn't get the same result. It was more or less like less than 50%. But in terms of, there have not been real evidence at this point of time whether the improvement in ocular blood flow can actually translate to an improvement, not an improvement, at an effect in preventing further deterioration in visual fields. Of course, this is not entirely your glaucoma case, but if you have the cohort of ocular hypertensive patients in the European glaucoma prevention study, right? So the European glaucoma prevention study is similar to your OHTS, where they randomized patients with ocular hypertension into the medical arm and the observation arm. And interestingly, the medical arm, they use dorzolamide. So you have a direct, impact of dorzolamide being tested there. And interestingly, the EGPS results are a little interesting because they did not find a huge benefit of dorzolamide in preventing the progression of glaucoma compared to the observation arm, which were given placebo drugs. And one of the problems was that the placebo reduced intraocular pressure by somewhere around 18 to 19%. So this was very unusual, though it was a large multicentric study conducted in various parts of Europe. The placebo itself reduced intraocular pressure by 18 to 19%. So while dorzolamide reduced intraocular pressure by 20 to 21%, when they did the statistical analysis, they found that there was not much of a difference in terms of. So one of the arguments is that if there is an actual ocular blood flow effect on preventing progression to glaucoma in ocular hypertensives, this should have been picked up in the EGPS, which was not picked up. But this is a case of ocular hypertensives. What madam said is specifically about certain patients with low mean ocular pressure, ocular perfusion pressures, ones with lower diastolic pressures, etc. Okay, so another basic question, Dr. Thomas Arun, you have started a patient on prostaglandin. We've all agreed that most of us in almost all cases start prostaglandins as the first line drug. And after starting the first line drug, you have found that you have not reached the target intraocular pressure. What is the next drug that you're going to add and how do you go about it?
Next drug, now in most cases, I'm going for a carbonic anhydrase inhibitor. The main reason being that brimonidine invariably over time, majority of them do develop local side effects. I think most patients, probably more than 50% of patients who are on brimonidine have coming back maybe 1 year, maybe 1.5 years down the line. So now I go for a carbonic anhydrase inhibitor, initially with twice a day, and then monitor them and then see how they progress.
Why not timolol, Dr. Thomas?
Timolol, I mean, if prostaglandin has given some reduction, and I mean, also considering the systemic side effects. So most of the, I'm not sure how much extra that timolol can do in addition to the prostaglandin, which is already being applied. So I usually go for a carbonic anhydrase inhibitor in the second line.
Okay, Dr. Meena Menon, what is your, I mean, nobody is nowadays talking about timolol at all. The two drugs people do not talk about are timolol and pilocarpine. And timolol has been around since 1978 and pilocarpine even more so. So what are the situations where you use timolol, and obviously what are the precautions that you need to take?
So, before prescribing timolol, as usual, you will rule out any other problems like, patient is an asthmatic or chronic obstructive pulmonary disease. Another important factor which we sometimes miss is a pacemaker. So we have to ask for a pacemaker. So any of these issues, if we have ruled out, many a time, if I want to achieve like something like 40 to 50% target pressure, I usually use a combination of prostaglandin with timolol after ruling out all other issues. So that comes kind of as a first choice. And if you ask me if I've put only a prostaglandin as my first drug, and then sometimes I want to add on a second drug, like I many a time prefers a combination of alpha agonist with timolol, again, after ruling out all other contraindications. And even in any of the circumstances, if they're very old patients, like 80 plus and all that, I again avoid an alpha agonist and I'll prefer a carbonic anhydrase inhibitor in those patients. And again, we have to look out for these nocturnal hypotension, because if the patient is already taking an antihypertensives at night, again, we have to find out about the antihypertensives and then probably avoid timolol as a BD dosage. So again, there has been a lot of studies looking out for whether the timolol once a day dose is to be preferred in the morning or in the night. After looking at various literature, I prefer to put in the morning, so that this chance of nocturnal hypotension will also a little bit taken care of.
Okay, madam. Dr. Meena Nair, your words on pilocarpine. What are the situations you are using currently?
See, pilocarpine, like you said, it's almost rarely used now. I still use it prior to laser iridotomy. Yes. You need to actually put it only once, but there are people who put it at 10-minute intervals about 3 times to obtain adequate meiosis before the procedure. That is one step. Then second, I think it may have a role in patients who have bilateral subluxated lenses, etc. If you want to keep the pupil meiotic. I have a patient who's had an ACIOL doing well, cornea is fine, but it's a flipped ACIOL, and to keep the meiotic, I have kept him under pilocarpine as a maintenance dosage to have a control over the pupil and keep it meiotic.
And in plato irises also, I suppose?
Yeah, plato irises. That's another very important place where you can use.
Dr. Menon?
Yeah, I use pilocarpine in one more situation, glaucoma and pseudophakias. So they do quite well, and especially as a last drug choice, yes, because sometimes in this glaucoma and pseudophakia, you have, the PCR and lens in sulcus, a foldable lens in sulcus. These might be the causes, a chronic pigment dispersion which is happening. All these can be the causes for a glaucoma and pseudophakia. So in such situations, many a time I avoid a prostaglandin, because if there is a chronic pigment dispersion which is happening, in such situations, I have used pilocarpine and I'm quite happy with those results. And of course, as Dr. Meena said, like free laser situations and an acute angle closure.
Okay,
and
we have
plato iris.
Yeah, we have about 3 minutes. So before completing the medical management, any opinions on the bimetoprost implant, intracameral implant, which has been approved for FDA use in US since about 1 year, but not available in India? Do you think that these basically delivery systems other than topical drops will have an impact? Anybody wants to comment? Dr. Thomas?
I'm not sure how much it's going to have an impact when considering that it's an invasive procedure, and also the long-term effect we really don't know. I mean, if the effect is going to wear off after some time, but I think patients would prefer once a day drops, bimetoprost actually once a day drops. I think patients wouldn't mind doing that.
Okay, Dr. Menon,
Yeah, considering the same interventional part of it, I don't know how many patients will accept. But as you all know, some of my profile of patients don't have time for anything in Bangalore. So they might want even to avoid putting this drops once a day also. Such situations probably they may adapt, because people have this fad for something which happens abroad, which has a good result. we have
Dr.
to
Meena
wait and
Nair, do you think that there is any role for drug delivery systems like an implant?
Yeah, I think it does have a role, but again, it is a difficult decision to take because if we're not able to follow up the patient, it will be very risky.
I think the idea behind using an implant is to increase compliance because obviously you don't have to put drops on a daily basis. The current approval is for one single intracameral injection only. That is the approval in March 2020. So the 10 microgram implant of pymetoprostol has been approved for single intracameral use. Though the studies looked at multiple injections. They have looked at studies of multiple injections at day 1, then week 16 and week 32. So they have looked at 3 injections. The approval is currently only for 1 injection. And I think the main reason was that with 3 injections, there was a possibility of the endothelial cells coming down. So they found that after the first injection, there was practically 0% of patients with endothelial cell drop, but after 3 injections, there was some endothelial cell drop, though not much of a change in the central corneal thickness per se. That is probably one of the reasons why an approval has been given only for 1 injection. And the problem with 1 injection is that the effect will last only for about 3 months. And if you look at patients after 1 year, only 36% of the patients do have some intraocular pressure lowering efficacy at the end of 1 year. So basically, majority of the patients, like 64% of the patients, would require an intraocular pressure lowering drug after the initial period of 3 months. Interestingly, if they had given 3 injections, the effect seems to last much longer. So after the 3rd injection, for a period of 1 year, if you follow up the patients, 82% of the patients did not have any requirement for any extra intraocular pressure lowering drop. So by increasing the number of injections, it seems to indicate that the duration of effect of the drug delivery system seems to work a lot more, and there are some theories regarding this. So any more, because I have not noticed any further questions in the chat box. So do any of the panel members have anything else to discuss, any comments to make, any advice to the audience?
I think compliance is something that we need to be careful, need to probe indirectly, as Dr. Rajul Parikh said, because very often we assume that studies have shown that patients, they put drops quite regularly 5 days before their clinic visit because they know they're coming for a checkup, So that is something we need to probe directly or indirectly and make sure it's happening.
Yeah. All right. So do you have any investigative questions that you kind of use to detect patients with poor compliance who self-report that they are perfectly adherent? Any tips?
Well, we ask them to bring the bottles when possible. That's one thing. And of course, look for any side effects, which is unfortunately not a good way of finding the compliance. But those are the methods we can ask. And sometimes it is sometimes the children who buy the drops, so we can ask them as well to bring them. Yeah.
I think in future, pharma companies are planning to put more than 2 drugs in 1 bottle. If that comes up and they're going to be effective, then it may be maybe a strategy towards improving adherence. Probably.
Okay, I think that it's time for us to conclude the panel discussion. I thank all the panel members. I thank Dr. Rajul Parikh, who is probably running around Mumbai today as far as the Glaucoma Week activities are concerned. So thank you to everyone, and thank you to the audience. And let's go on to the next session.
Thank you, Dr. Kiran.
Thank you, Kiran. Thank you, Ksos.
Thank you.
Thank you. Bye.
Thank you, Dr. Kiran Gopalakrishnan, and all honorable panelists for that informative and much needed session. A special mention to the discussion, which was very enlightening. Without further ado, we move on to the next segment of our CME, which is surgical glaucoma, MIGS, present position in our armamentarium, followed by a panel discussion on bits and tricks for a successful trabeculectomy in MIGS. I warmly welcome Dr. Saikumar S.J., Senior Consultant, Giridhar Eye Hospital, Ernakulam, to chair and moderate this session. Dr. Saikumar completed his MBBS and MS at Government Medical College, Trivandrum, Throughout his career, he has graced various posts in KSOS, including his career Honorary General Secretary, Chairman Scientific Committee, Editor Journal, Website Editor, etc. He is currently the President-elect of KSOS. He has numerous papers, posters, and instruction courses at the state, national, and international levels. He was also the past president of Cochin Ophthalmic Club. He has been generously sharing his knowledge, working as a DNB teacher for the past 12 years. Over to you, sir.
Good morning, ladies and gentlemen. Thank you to the Kasaragod Ophthalmic Society and, of course, the main persons in KSOS for organizing such a wonderful webinar on glaucoma on this, the beginning day of the World Glaucoma Week. It's indeed a great pleasure to be, chairing this session, and giving the keynote address in this session is none other than Dr. Swathi Upadhyaya, who is a senior consultant at Aravind Pondicherry. And when I requested Dr. Venkatesh to suggest someone to talk on MIGS, he said probably she's the best person in India today to speak on MIGS. So that's a great compliment coming from your boss, Swathi. And so here she is. She's going to share with us all her experience about MIGS, what its current condition is in the armamentarium of glaucoma, surgical procedures as far as the Indian scenario is concerned, which are accessible to us in our country, which are the very expensive MIGS, which probably we may not even use, and how much or will it ever replace a filtering surgery or a routine glaucoma surgery or a tube shunt in the future management of glaucoma. So we are very eager to hear from you, Dr. Swathi. And along with me in the panel, we have Dr. Venkatesh also, who will be sharing his experience. We have Dr. Ajith from Shankara, Coimbatore. We have Dr. Thomas George from Trivandrum, who will also be part of this panel. All very senior glaucoma surgeons with many years of experience. So I'm sure we're going to have a great session. So we'll begin with the keynote address by Dr. Swathi. Over to you. You can share your screen and begin the keynote address.
Yeah, yes. First of all, good morning, everyone, and thank you, KSOS and Kasaragod Ophthalmological Society and Dr. Saikumar for giving me this opportunity to deliver the keynote address and on present position of MIGS in the glaucoma surgery armamentarium. I'm really honored and overwhelmed, and thank you for the nice introduction, sir. Sir, I hope my screen is visible.
Yes, very much. Please go ahead.
So, for the next 20 minutes, I'll be taking you through the various procedures which are feasible in India. So, I'm Dr. Swathi Upadhyaya from Aravind Pondicherry. I have no financial interest, and as we all know that a gold standard for glaucoma surgery still remains trabeculectomy. So, whenever in a developing country where most of the people do not have access to MIGS, they feel like, okay, fine, there is a cupping, there is cataract, and let's go ahead with trabeculectomy. So it's very nice to see a very minimally avascular, well-defined, elevated bleb and with pressures under control, and you feel really happy. But challenges with TRAB are that it causes 40 to 48% only IOP reduction in 3 to 5 years. And it is an invasive procedure indicated for patients where benefits outweigh the risks. And there is a definite learning curve. So when we teach our fellows trabeculectomy, it is not easy, and we have had our share of complications. They have their own share of complications while learning trabeculectomy. And doing a trab is not the work done. It's the meticulous post-op follow-ups which are more important than just the surgery itself. And that is a challenge in the developing world, where the patients have poor compliance to medications, poor compliance to post-op follow-up visits. And sometimes we do need interventions like bleb massage, 5-FU injections, and needling, which also is a burden for the patient as well as to us also, because it might be that first one bleb massage might not be enough. One bleb massage might lead to hypotony, or If the patient doesn't come for a follow-up, there might be a tenant cyst forming over the bleb, or there might be an overhanging bleb with the excessive use of mitomycin C, or in the most dreaded situation, if the patients have not used antibiotics or steroids properly, they might land up with blebitis and then endophthalmitis. So TRAB, although is the gold standard for for glaucoma management, it has its own sets of complications, and everything goes on well fine. If not, then what? So what about mild to moderate glaucomas where you don't want to take all these risks? And what about NTG, normal tension glaucoma, where you do not require very low target IOP also? And you might be thinking that whether I should put one suture or 3 sutures on the flap, or what if the patient develops hypotony and macula snuff out? Then again, you have dilemmas with ocular hypertension with healthy optic nerve head, where you just want to control the pressure and you do not want to have any other complications. What about ocular surface disorders? Because after TRAP also, the patient has to put antibiotic steroid combinations for at least 8 to 10 weeks in our scenario. So we give around tapering doses of antibiotic steroid for about 82 days. What about monoocular patients, where also we think 10 times before opting for a TRAP? Where patients have high chances of macula snuff out, yes, again, it's a dilemma. And where that eye is very precious to the patient. And what about systemic comorbidities, where patients can't come for regular follow-up? We'll call the patient for releasable suture removal at around 10 days, then again 10 days, and the patient's attendance will be so apprehensive and so inconvenient that we can't come for follow-ups. So to answer all these questions, we have MIGS, minimally invasive glaucoma surgery. So the cardinal features are that MIGS are mostly ab interno microincision procedures, except for, I would say, micropulse laser, which is an ab externo procedure. And all of the MIGS cause minimal trauma to normal anatomy and physiology of the eye, and they should have demonstrable or reliable IOP lowering and medication reducing capability. They should have a high safety profile, and they should have rapid recovery with minimal need for follow-up. So these are the cardinal features for all minimally invasive glaucoma surgery given by Sahib et al. Classification of MIGS, they can be procedures which increase the trabecular meshwork outflow, like trabectome, eye stent, GAT, Kaushik dual blade, hydrous implant. Trabectome, eye stent, GAT are approved in India, but Kaushik and hydrous are still not approved in India. So we don't have them. Suprachoroidal drainage can be SIPAS, and eye stent supra still not approved in India. Subconjunctival filtration in the form of Zen gel implant or Infocus still not approved in India. And procedures that reduce aqueous production like ECP and micropulse. So this we have. So the extremes, the right extreme and the left extreme we have, but the rest we don't have it as such in India. So these are the developing world options: suture GAT, bank, eye stent or eye stent inject, trabectome, ECP, and micropulse laser. So I'll take you through all these one by one. Gonioscopy assisted transluminal trabeculotomy was developed by Davinder Grover et al. In 2014, which it cannulates 360 degrees of the Schlemm's canal by passing a proline suture or an eye tract microcatheter and creates a 360-degree trabeculotomy. Eye tract microcatheter is still not approved in India. So the instruments used for GAT are low temperature cautery, Swan-Jacob gonioprism, 5-0 proline suture, 15-degree side port knife, cohesive viscoelastic. Orogel is very good, and it is as equal to Hilon GV, 25 gauge MVR blade, MST forceps, McPherson's forceps, and an indirect gonio lens. So this is a short video showing. So I'm blunting the tip of the 5-0 proline suture. Then I blunt it on both the sides of the suture. Then we create a paracentesis for introducing the suture. So this paracentesis should be towards the nasal angle, and it should be just enough for the suture just to be introduced. Then you create a temporal paracentesis or temporal incision for your MST forceps and MBR blade to be introduced inside. This is Orogel or Hilon GP I'm using to form the anterior chamber. Then introduce the proline suture, the blunted tip of the proline suture inside. Put a drop or a dollop of OVD. Turn the patient's head away from you. Tilt the microscope towards you. This is what I'm doing here. Adjust the table height so that when you put the gonio lens, you get the view of anterior chamber angle. So this is the blood in the Schlemm's canal, which we can see. By using the 25 gauge MVR blade, I'm just going to do a limited goniotomy of around say half to 1 block-hour, just enough to create a space for the blunted tip of the proline to be inserted into the Schlemm's canal. Using the MST forceps, we just thread the suture tip into the Schlemm's canal, and with gentle strokes, we keep on pushing it inside the Schlemm's canal. Now, for the initial few cases when we are not sure whether the suture is exactly in the Schlemm's canal or not, we should use indirect gonio lens, which I'll be showing in a few seconds. So this is the indirect gonio lens where you can see the blue color of the proline being seen in the Schlemm's canal. So the blue color really helps for us to identify, and you can see till what extent you have introduced the suture. So here you can see that this suture has reached up till one stage, and then you know that you are still there in the Schlemm's canal. And see, now the suture is appearing from the other end. So just keep on pushing till it appears to the initial goniotomy site. Now it has appeared at the opposite side. Just catch hold of the tip and hold it above the suture which you have introduced earlier, so that your suture doesn't get entangled at the temporal side. Just using the McPherson's forceps, just pull the suture out gently so that it will create a 360-degree trabeculectomy. So that is, we are opening the inner wall of Schlemm's canal. So this is how then you wash the viscoelastic and proceed with the phaco. So hyphema post-grat is very, very common. Either you can have a dispersed microhyphema or you can have a layered hyphema or a blood clot. So we ask the patient to sleep on the side of surgery so that whatever blood is there, it trickles down to the temporal side so that the nasal part, which is having the maximum collector channels, still remains unoccluded. 90% of the hyphemas resolve within the first week, and late hyphemas are very rare. Now, coming on to bang or bent ab interno needle goniectomy, it is an alternative to Cahoog dual blade. So we use a 25 gauge hypodermic needle, bent it at 90 degrees. And why 25 gauge? Because 26 gauge is too small to reach the nasal angle, and 24 gauge is too huge for the trabecular meshwork and can cause cyclodialysis. So this is a video of me doing first a phaco and then a bang. So after completing your phacoemulsification and intraocular lens implantation, you put a cohesive viscoelastic inside the anterior chamber and on top of the cornea, bend the tip of the 25 gauge needle, and then under gonioscopic visualization, take the needle inside and identify the trabecular meshwork and introduce the needle into the trabecular meshwork, and just like shearing away, you have to just cleanly make scratches, or you can just tear the trabecular meshwork off. So as if you have bleeding, so this is a good sign, because then you know that yes, you have opened up the Schlemm's canal and the collector channels have started bleeding inside the anterior chamber. So you can just see that these are the bleeders. So these are 1, 2, 3, 4 bleeders, and then you go ahead with the aspiration of the viscoelastic. And also, as a tip, I would like to say that we can use pilocarpine also before proceeding with bang. Now, this is the way. Look at this vessel. So when you have created this limited trabeculectomy, this vessel should start draining. So how do we confirm? So this vessel has got blanched now. And again, after some time, it will reappear. So this means that you have opened up the trabecular meshwork on the nasal side, or the Schlemm's canal on the nasal side, and it has started draining. So this episcleral venous wave is very important, and it shows that yes, the chances of success of surgery are high. Now I come on to the eye stent trabecular micro bypass, or TMB. So it was US FDA approved in 2012 for use only with combined with cataract surgery. It measures around 0.3 millimeters snorkel and 1 millimeter in length. It has got 3 retention arches, and it is non-ferromagnetic heparin coated titanium device. It can be introduced to 1.5 millimeter clear corneal incision, and the long arm rests within the Schlemm's canal, anchored by the 3 retention arches, and also it is safe when patients are undergoing CT or MRI. So as you can see on the right hand side, there is an eye stent placed in the trabecular meshwork. Now we also have iStent inject, which are the smallest FDA approved devices, which measure just 0.5 millimeters, and they come in a pair. In one trocar, there are 2 iStents which you have to implant into the trabecular meshwork. So this is a small video showing iStent inject. So you can see there is a trocar. So you have to pinch onto the trabecular meshwork. You have to indent, make a dent on the trabecular meshwork. And once you are sure that you are indenting the trabecular meshwork, you just press the trocar, and then one iStent gets just comes out, and then it gets introduced into the trabecular meshwork. And so you can see that there is bleeding from the collector channel or from the iStent. After having done this, you can still confirm by using OVD. You can just remove the blood. After this, there is another iStent in the trocar. So you have to again fill the anterior chamber with viscoelastic. Go ahead. And then take another position at around say 2 to 3 clock hours away from the first position. Again, we have to be very sure that we are at the trabecular meshwork bang on. We should not be below the trabecular meshwork or at the ciliary body band. Then it will cause a lot of bleeding. So after you have indented, make a dent. So you can see the small iStent inside that trocar. Once you create a good space, I mean you are at the right position, just press the button, and then the iStent will be injected out, and it will lie half inside the trabecular meshwork, and the foot plate will lie outside at the trabecular meshwork. And once you are done, you can see bleeding coming out from the iStent. So this is the last, which I'll be showing that you can confirm the position of the iStent. So you can see very clearly that still it is bleeding from the iStent on both the 2 positions. So you have an iStent, 2 iStents implanted at 2 or 3 clock hours apart. Now we come to trabectome. So trabectome is a single-use disposable 19.5 gauge handpiece that has an electrocautery, irrigation, and aspiration. So we make a 1.8 millimeter clear corneal incision, inject viscoelastic inside the cornea and top of the cornea. Then just view and verify the angle structures. If the angle structures are not visible, you can wash off the viscoelastic, put pilocarpine, and then re-inject the viscoelastic. Then again, under gonioscopic visualization, we take the trabectome probe inside, and this this wire delivers a radio frequency current of 550 kilohertz, ablates the intervening trabecular meshwork for up to 180 degrees between the wire and the tip. So you see that golden thing, it is there to protect the posterior wall of the Schlemm's canal. So you do on 2 clock hours on either side. So at least you can get 4 clock hours of trabeculotomy. Then we come on to endoscopic cyclophotocoagulation. It has got a light source, an endolaser, and video endoscope in a 20 gauge single probe. It can be done through a clear corneal, limbal, or scleral incision. The endpoint being a whitening and shrinkage of the ciliary processes. It is useful in patients with angle closure glaucoma. So the normal settings which we use is 1000 milliwatt, 0.1 to 0.2 seconds duration, 3 to 5 laser exposures in each process, and 2 quadrants opposite to entry side we should do. So this is a video courtesy by Dr. Vanita Patakare. She is the one who's she has been courteous enough to give me this video of hers, because we don't have ECP in our institute, but this is the way she does. She goes with the endoscope, she identifies the ciliary processes, and then just gives laser energy. So the ciliary processes just shrink. So depending upon how much pressure control you want, you can target the number of ciliary processes. So this is useful in angle closure glaucoma patients where your trabecular meshwork is obscured by the iris. Even if you do goniosynechiolisis, there is a tendency for the iris to go back and cause a peripheral anterior synechia. So this is a procedure which is behind. So after doing this, after doing a cataract surgery and an ECP, your iris also falls back. There is posterior, the iris lens diaphragm also goes back. So indirectly, your angles are also opening up, and also you are reducing the intraocular pressure. Now, micropulse laser. It is a tissue-sparing solution for the treatment of retinal diseases and glaucoma. It uses 810 nanometers laser. It is a continuous wave laser beam chopped into train of short, repetitive, low-energy pulses separated by brief rest periods. Now, what is the logic? So, the on time is typically 100 microseconds to 300 microseconds. So, each pulse, so it limits the thermal elevation and thermal dissipation to the adjacent tissue. So the off time, what does off time, which is generally 1700 microseconds to 1900 microseconds, is the interval between consecutive micropulses when the tissue cools down between the laser pulses. So it's not a continuous delivery of laser. So having said all these MIGS procedure, does MIGS really work? Now I'm going to give you some evidence. So this is a study done by Davinder Grover et al. In eyes which had already undergone prior incisional glaucoma surgery, and they found that still GAT appears to be safe and successful in treating 60% to 70% of open angle glaucoma patients with prior incisional glaucoma surgery at 24 months follow-up. So this surgery should be considered in certain patients with failed trabeculectomies. Now, what about angle closure glaucoma patients? Another study done by Fontana et al. Have shown that at 12 months follow-up, GAT in CACG patients effectively reduces IOP and the number of medications with lower risk of complications, and at 12 months post-op, an open angle without pass was achieved in majority of patients. So it's not that angle closure glaucomas are a serious no-no to any of these MIGS procedures. Now, KDB, a retrospective study done by again Conman et al. From Glaucoma Associates of Texas, they showed that Kahook dual blade results in a reduction in IOP and anti-glaucoma medication at 1 year follow-up. So then prospective study also was done by Greenwood et al., where they also proved that single-use KDB plus phaco resulted in a significant and sustained reduction in IOP and number of glaucoma medications at 6 months follow-up. There are many studies which we can just quote, keep on quoting to show that MIGS works. Now BANG. So there have been no published data for BANG as such. Only this RO abstract is there by Jackson et al., which shows that that BANG is a procedure which is economical option, and when combined with cataract extraction demonstrate greater than expected improvement in IOP. And for phakic patients, cataract extraction BANG may represent a viable first step instead of more conventional invasive surgical intervention for glaucoma. What about iStent TMB? It also shows that it is 4% reduction was achieved from baseline when we did a phaco emulsification as a solo procedure, compared to 9% when we did phaco plus iStent, and in contrast to 27% when we did a phaco with 2 iStents. So that means the more number of implants you put, more IOP drop will be there. But the sad side is, or the flip side is, that with more implants, the cost to the patient becomes increasingly more. So this is a study by Katz et al. Who have said that with each additional stent resulted in significantly greater IOP reduction. Trabectome. Outcomes of trabectome surgery in patients with low, middle, and high preoperative intraocular pressure showed that patients with preoperative IOP less than 18 millimeters, it was difficult to decrease their IOP more than 20% with trabectome surgery, and they usually required additional glaucoma surgery. So this is data. Trabectome usually doesn't work so well as the other MIGS, I would like to say, because I have also done some trabectome cases. But Dr. Sunita Dubey is yet to publish her data, and she has got really good results with trabectome. What about endocyclophotocoagulation? A study by Lin et al. Has shown that eyes with CACG were more responsive to phaco ECP in terms of IOP and medication reduction as compared to eyes with POAG. So ECP really works in patients with angle closure glaucoma. Micropulse laser, there is only one study done in Indian eyes by Dr. Murli Ariga et al. And sir has said, Dr. Ariga has told that it's a prospective study, and it shows that initial experience in Indian eyes shows that MP, like the micropulse transscleral cyclophotocoagulation, is safe and effective for refractory glaucoma, and patients can expect significant IOP lowering along with reduction in number of medications used for controlling IOP. So mixed scenario in India as of now is that Kahook is not approved in India. Eye track catheter is not available in India. Trabectome, yes, it is approved, but one probe costs 52,000 rupees. Eye stent also costs 70,000 INR, and a pair of eye stent injects costs 1.56 lakhs. On the other hand, bang, which just requires a 125 gauge needle, which is 75 INR, and Prolene Suja, which just costs $10 US. And from one Prolene Suja, you can do at least 5 to 6 cases. You can cut it into pieces and you can use them for 5 to 6 cases. So overall, if you see that bang and GAT are very cost effective or low cost alternatives, and if the patient is affordable, can afford, an eye stent inject can be an option for them. So I would like to say that mild POIG, if the patient comes, bang or eye stent is a good option. Moderate POIG, you can try GAT or eye stent inject or bang or trabectome. Normal tension glaucoma patients where you just need minimal surgery and the pressures will be in the lower teens or maybe single digits, you can have an eye stent or a bang or a trabectome. Ocular hypertension with healthy optic nerve head, yes, go for a bang depending upon the number of medications the patient is on. Sometimes the ocular hypertension may be on 3 to 4 medications, so then you should go for a GAT. If the patient is just on one medication, you can do a bang. Monoocular patients where you can't risk them to have a hyphema, as in GAT, we get in GAT, I would say that eye stent or bang is a good and safe option for them. Patients with high chances of macular snuff out, definitely no invasive or no cutting procedures. I would like to do a stenting procedure for them. Patients with systemic comorbidities who have a difficulty in follow-up, yes, eye stent or trabectome. And patients with ocular surface disorders, you can have any of these mixed procedures depending upon their affordability or their optic nerve status. So to conclude, MIGS can prevent major bleb-related complications and yet be efficacious. Suture GAT and bang can prove to be low-cost alternatives to conventional ab externo procedures in the developing countries. Eye stent phaco can bring a revolution in glaucoma management. And why I say this revolution? Because mild to moderate glaucomas can be dealt with by phaco surgeons themselves if they get enough training in eye stent implantation. So what will happen is that only the very severe glaucomas or glaucomas which are intractable will be referred to the tertiary eye care centers or to the glaucoma specialists, which will reduce their burden also. So it's not that we can't do mild to moderate, but yes, our burden will also be shared by the phaco surgeons as well. Trabectome and micropulse can be cost effective on pooling together of patients, because one trabectome, if you have 3 probes, one tubing, you can do 3 cases if you have 3 probes. So tubing is a major problem in trabectome, and which one tubing will cost 52,000 rupees. Micropulse also, one micropulse will last for only 60 minutes or say 90 minutes. They say now the company is making it lesser making it more difficult for us, because previously surgeons used to do 10 cases with one micropulse probe, but now it has come down to 3 patients. So if you pool the patients together in one day, then these procedures can be cost effective. Endocyclophotocoagulation can be a real boon for angle closure glaucoma patients. So the take-home message which I would like to give is that MIGS is the future and it is here to stay. Let's start practicing intraop gonioscopy. Start with bang, which is the basic or say minimally expertise needing surgery. And with practice and perseverance, MIGS is not a dream far-fetched. But well-designed randomized control trials are required to prove efficacy in Indian population, and we need to prove non-inferiority through trabeculectomy. Thank you so much.
Thank you very much, Dr. Swathi. That was a wonderful overview of all the mixed procedures and a very frank, talk about what all is feasible for us and what all in the Indian scenario you have done over the last few years. Now, as you mentioned in your talk, one of the most of these, except probably the photocoagulation and the micropulse diode, the rest are all angle-based procedures.
Yes, sir.
As you very rightly said, the first thing we all have to do is to practice, good intraoperative direct gonioscopy, get familiar with exactly, where the trabecular meshwork is, and then start with probably bang first, and then move on into the other procedures.
Yes, sir.
Which is the needle that you use for your bang procedures?
It's a 25 gauge needle. So it is 3 centimeters long. So it will reach the nasal angle very conveniently. So I use 26 gauge also, but it is only 1.5 centimeters. So it doesn't reach the nasal angle so well. So 25 gauge is good, sir. If you have access to 27 gauge is also good. 30 gauge becomes very, very minute. So it might not be that effective as 25 gauge needle, sir.
And you also mentioned that, all these angle-based procedures are for, the good open angles and not the angle closure ones. But do you have experience in removing the cataract first in angle closure setting and then doing a angle procedure?
Yes, sir. So I did goniosyncytial also. Then I did the bang or GAT also. And sir, pass also forms after GAT and bang and trabectome. So in GAT, bang and trabectome, where you end your trabeculectomy, there pass happens. So that is the area where you have more rigid or the friction between the normal healthy tissue and the excised tissue. So there pass will form, but these pass are not broad based. They never cross and they just do not create a creeping angle closure kind of a picture. So they are just localized small base pass. So it's safe only, sir.
Dr. TG, your comments.
So I want to ask Swathi one thing, because this is one place she has much more experience than me. I always do my GAT before the cataract is done.
Okay.
Would you? It's easier that way, is what I think.
Yeah.
And then proceed to the cataract.
Correct, sir. I also do that same, because after doing a phaco, that main incision becomes a little larger, and it is more leaky. So the OVD tends to come out and escape when your anterior chamber, when you put the lens on top of the cornea, it gets DM folds and your view is hampered or obscured. So again, you have to keep on injecting viscoelastic into the anterior chamber. And sometimes, sir, after phaco, what happens? There is blood in the Schlemm's canal, and when you just give the initial goniotomy, it starts bleeding so profusely that you cannot go ahead with any of the angle procedure. Then you have to keep on washing, wait for some time, tamponade with air or viscoelastic, and then go ahead.
I've been using a hell of a lot of sodium hyaluronate in this situation. Push the blood away and then proceed.
Yes, I agree, sir.
Dr. Ajith is here. Dr. Venkatesh.
Yes, sir. Am I audible?
Yes.
Yeah. Hi, Dr. Ajith. Good morning.
Morning, sir. Morning,
and welcome to our panel. Any comments on the mixed procedures, your experience, before we take up some questions?
The video shown by Dr. Swathi was exemplary, but I don't have any exposure in MIGS other than micropulse, which I have done for a few refractory glaucomas, and patients post-trabeculectomy on multiple medications developed allergy, and it has worked well, and we were able to bring down the IOP. But as far as GAT or other procedures, I have not experienced it.
Ma'am, just start doing ectop gonioscopy.
Yes.
Okay, so since Dr. Ajith mentioned about micropulse, I think we'll take it up the questions from there. When this was introduced a few years back, we all thought that it could be used a lot in many refractory glaucomas, in patients with allergies and things like that. But over a period of time, what is the data that is accumulating in the Indian scenario regarding micropulse? Everyone was saying cyclogy is the in thing, but the initial enthusiasm seems to have slowly waned down. What is the present literature or the present experience from Indian eyes tells us about micropulse diode? Dr. Swathi?
So we don't have in our center, but for what I've been hearing from our colleagues in other centers is that it doesn't really work so well. Sometimes it works, sometimes it doesn't work. So you cannot predict how much it will work. So when we have some patients who are like very precious eyes on maximum medication, we send them for a ECP, a micropulse. They got the micropulse done, but again after some time, one drug, another drug, and it came back to square one. Again, the patient was on maximum medication. So the predictability of micropulse is little doubtful. I don't know Ajitha ma'am's experience.
Yes. The predictability is doubtful, because the initial we also found that the initial IOP drop did not persist later on. and we had to restart medication in many of the patients.
I think initially Dr. Satyan was a person who was doing a lot of micropulse in Coimbatore. So, but over a period of time, I think the enthusiasm seems to be slowly waning, and more focus is now on MIGS, I think. So we'll take a few questions on trabeculectomy in general. This is for all the panelists, TG, Dr. Ajith, and Swathi. What is your personal protocol for using mitomycin C? Do you use mitomycin C in all your cases? If not, which are the cases you would avoid? What is your personal experience? I mean, this is a general question for all the audience who's listening to this.
So should I start?
Yeah. Can you start, please? Yeah.
So we avoid mitomycin in patients who are normal tension glaucoma patients, who are high myopes, and or who have other eye very disfiguring or overhanging blebs. So we avoid the other eye MMC. Nowadays we have switched over to, from sponge, we have switched over to injectable mitomycin, subconjunctival injection of same concentration, but we give it as a subconjunctival injection. And for patients who are high myopes, we use Ologen or nothing at all. And for patients with very heavily pigmented trabecular meshwork, we use higher concentration or same concentration for a longer duration, say maybe 3 minutes or 4 minutes.
TG, your comments. You are a big Ologen fan, I know.
Actually, I use mitomycin on all my traps except when I'm using Ologen. Only thing is, I also use injectable. Injectable, I feel, is you titrate the actual dose. Sponge, you have no idea how much is sitting in each sponge, each surgery. So injectable, all I do is when the patient is younger, myope, where you expect a long-term hypotony coming in, I reduce the dose to half of what instead of 0.1, I inject 0.05 of the mitomycin that I put subconjunctivally.
The same dilution that we use for the sponge?
I use 0.4 per ml, the higher of the sponge dilutions.
So we use 0.2.
Okay.
For 2 minutes.
0.1, no, in the injectable.
But Swathi, when you're using an injectable, there's no minutes involved.
No minutes. So
no minutes involved.
Sponge.
So sponge, there's 2 minutes for whatever.
For the fellows, we still stick to sponge, sir. Okay. The consultants have shifted over to injectable. So we don't wait, just give injection, we start peritomy.
Yes, that's another advantage of injectable. You don't spend some time wondering what to do with yourself. And other thing I do is I inject from the limbus side, not like what was described. I just keep going subconjunctivally, like for a posterior subtenon injection for steroid. And I include that in the incision because I found a couple of my injection sites were leaking later on post-op. So I include that in my closure.
And so which
Dr. Ajith, yeah. Sorry, please go ahead.
So we use 30 gauge needle so that the initial point is very minute.
Very small. I use a 26.
So I use mitomycin in almost all my patients except high myopes, and I use a sponge 0.2 mg. Yes.
So this injection, how do you exactly ensure the plane? Do you really go subtenons or subconjunctival? And if it doesn't go into the exact plane, what is your change in plan?
Shall I take it?
Yeah.
I go in like posterior subtenon. It's subtenon that I inject. And immediately after injecting, I use a hydrodissection cannula and send some more saline into that same track so that it dilutes and spreads. 0.1 is a very small amount. So you inject, you roll a cotton pledget so that you push it backwards. And then I put in a little more saline to sort of make it a bigger bleb and then go ahead with the peritomy. It's very easy to get subtenon. You pick up I also do one thing. I use a Hoskins to pick up the conjunctiva in front of the needle as I push it down.
Do we need to dilute the mitomycin further for injection, or you take the same concentration? What you use for the
same as what I use, 0.1
Okay.
So we give on the limbus on the fornix side 7 to 8 millimeters away from the limbus. by making a pinching of the conjunctiva and going beneath it. So we feel it is subconjunctival, but we actually can't know whether it is going subconjunctivally or subtenons. But yes, the ballooning of the conjunctiva is good enough that, okay, yeah, it is there. And then we use the Johnson bud or so to spread it on both the sides and to push it away from the limbus. So we roll the cotton bud from limbus towards the fornix.
By the way, what Swathi described is what is first described by the Singapore team where this all started. It's the limbal injection is my modification to it. What Swathi described is what has got literature backing.
So we used to use 26 gauge needle, but then as Dr. Thomas said that it was a leaky at that area, then you have to put another small nylon or vicryl there to seal that leak also. So we shifted over to 30 gauge needle. So now it is okay.
Okay. One more, area where many of the glaucoma surgeons do find is the bleb that is about to fail. And one of the things that we do is the 5-fluorouracil. So I would like to know your experience about 5-fluorouracil. How exactly do you use, and what has been your experience with 5-FU? Can I start with Dr. Ajitha?
I don't use 5-FU, sir. I use mitomycin. I go for bleb needling with mitomycin. And that is after trying all the other ways, like, whether patient bleb massage and steroids.
Sutures,
releasable sutures. Yes.
5-FU comment?
Yeah, so we give 5-FU after needling. So external bleb needling, sometimes it is just subconjunctivally, or sometimes we do go internal, like through the ostium we go internal bleb needling also. And then on the opposite side in the inferior fornix, we give 0.1 ml of 5-fluorouracil. Also, off late I've been doing internal bleb revision, so using Grover spatula. So it's like a cyclodialysis spatula, but it is bigger than that. It is around 13 millimeters the length of that spatula, and it is a little convex also. You identify the ostium using an indirect gonio lens. You keep it on there. Opposite side you go with the spatula, enter the ostium. Then through the ostium you go out, come out below the flap, and then below the conjunctiva. So this whole spatula is blue colored. So you can see actually what your spatula is, where your spatula is. So that is internal bleb revision, and I've got really good results with internal bleb revision, sir. So all the older blebs also, many years down the line, they were failing. So when the patients came for phaco, I combined the phaco with internal bleb revision. And now the patient is off the medication. So Grover spatula is really working great, sir.
So you place a gonio lens and then do it.
Yes,
it is the ostium.
Yes, indirect gonio lens. You cannot do it with direct because the patient
correct.
That head cannot be tilted, and you cannot tilt the microscope because you have to keep the coaxiality of the microscope and the patient. So you have to use an indirect gonio lens.
So you have a sterile indirect gonio lens on your operating table, and you use that. I have not done that. TG, have you tried this? And looks interesting.
I've been doing internal revision for a long time. And my record for the oldest trap that I've managed to retrieve is 20 years old. So it works even in very, very old traps. So I am a fan of this procedure. Initially, when I used to do it, I was not doing gonioscopy peroperatively. I used to mark it out very clearly in OP so that I know where the ostium is. And I place a paracentesis appropriately, and I use a regular phaco left hand for doing this internal revision. So I can go a little tangential. I don't need this much length. And now I do use an indirect gonio lens and identify it till the spatula is inside the ostium. Then I take it off because you need a fair amount of force to dissect out that old scleral flap.
Correct. Agree, sir.
So you can't be watching it as you're doing it. Only to get it in and make sure you're not going in for a cyclodialysis. I do use a sterile indirect gonio lens for the same. I've been lucky to have a friend in UK who has handed me a lot of his old used Zen gonio lenses. So I got a huge collection sitting in the theater which are sterile.
Those are supposed to be disposable ones.
Yeah, I know. But then he didn't feel like adding to the carbon footprint. So I use it and they can be used forever.
Sir, I also got it as a goodwill from Davinder Grove when I went there. So they were throwing those gonio lenses in the dustbin. I said, please don't throw them. I would be very happy to take them to India and use them.
By the way, the gonio lens that I use, my preferred gonio lens for GAT also is the Einstein gonio lens from the same person. I've been reusing and reusing forever.
Yes.
Okay, now slightly off track from what we are saying. Do you, any one of you use, before you go in for a filtering surgery, patient one maximum tolerated medication, do you use SLT or MLT? Because I know there is no special session on lasers in today's meeting. So just for people who would be interested to know about that, as a temporizing procedure, what is your experience? Has it held IOPs for a significant point of time, or most of them finally ended up on the surgical table for a filtering surgery? What is your experience? Dr. Ajitha?
No, sir, I don't use lasers. I go in for surgery if.
Okay.
Yeah.
So we also don't have SLT or ALT here.
Okay. So you are all directly going into surgery.
Yeah.
EG?
I'm also an incisional surgeon. But then when you're already committed to surgery, why add to the inflammation? That's my only question on this.
Okay, so not too many fans for SLT or MLT, even as a temporizing procedure in a maximum tolerated patient who is most probably going in for surgery. Okay. Now, regarding the endocyclophotocoagulation, which you mentioned, Dr. Swathi, I've seen a few videos from Dr. Gauri Murthy. I think quite some time back, she was using quite a lot of these, combined with phaco. Even in the slightly narrow angles, phaco is done, and then you do the ECP. But somehow it has not become a very, very popular or a very commonly done procedure. Is it because the IOP reduction is not predictable, or what is the titration that is used? I mean, how much of angle do you ablate? I mean, how much of ciliary processes do you ablate for what sort of intraocular pressure? Any comments on that?
So we don't have ECP, but I have been talking with Dr. Vanitha ma'am. So she does it around, say she's able to treat around 120 to 140 clock hours, like all the ciliary process on the nasal side when she does it combined with phaco, and she has got good outcomes. So I don't have any experience with ECP, sir.
TG, Dr. Ajitha, anyone has any experience?
No, I don't have ECP with
no,
me
sir. No.
Okay. So any other questions regarding our session? Any comments? TG, you want to add something?
I'd like to add, MIGS is, coming in a big way. It looks great, but the real skill is gonioscopy, and that is where it's going to catch everybody. And perioperative gonioscopy, you need to be absolutely clear about your anatomy, and it's all about positioning the microscope and the patient. Swathi did underline it. That is all it is. The actual incision and pushing the thread and all that is not a big deal. It's absolutely not a big deal. That's again the place where if we start pushing it for phaco surgeons, that's where we're going to fail. Because, I mean, among the glaucoma surgeons itself, I would say a few are lacking in this skill. That's my personal opinion.
So I would like to say that Bang also has a curve, because I've been teaching Bang, but sometimes you are there at the trabecular meshwork, but when you are incising, you just go down and you just create a cyclodialysis cleft. So it's just millimeters, or say microns, just
microns, not millimeters.
Not even millimeters.
Microns,
Yeah.
It is just there, and if your just hand just goes little down and you go ahead, then you create a cyclodialysis cleft. So you have
cyclodialysis cleft itself may reduce the intraocular
pressure.
Yeah,
it'll be more effective.
It may be even better than the. Any other questions or comments, or we can slowly wind up this session and hand over to the next session on pediatric glaucoma?
Yeah, that's to me. We have time here. The other thing is, it's all these retrieval procedures, needling, cyclodialysis, all of them. Be prepared to go into hypotony, because that does happen quite often. We are not, glaucoma surgery is not like cataract surgery where things are very controlled. One thing that I insist on all my patients who come to me for TRAB is at least 6 weeks. I need weekly follow-up. You should be committed to that. After 3 weeks, I may say he is safe, but then he should be committed. Otherwise, I don't do the TRAB on that way, because we have a lot of patients from Mali coming here. They want to finish it and go off 2 days after the surgery. And I say, please get more time and come back.
Agree. Totally agree, sir.
And what is your, I know that TG does a lot of halogens. Which are the ones that you use halogens? Which are the ones that you use mitomycin? What is your decision making?
Questions to me?
Yeah.
Okay. I have actually done a study on halogen versus mitomycin. They're absolutely comparable in my hands. There's no real difference. So if a patient chooses halogen, I would go for halogen is one thing. Other thing is, subjectively, I feel mitomycin does affect the ocular surface a little bit, though patients do not finally complain about it. They've been putting 3 drops and the dry eye, because the 3 drops is worse than post-surgical dry eye. So they're actually probably better off. But then the eyes do look a little redder. So if there's a borderline dry eye, if there's an ocular surface problem and I still need a trabeculectomy, I would try to convince them to go for an halogen. There is a significant cost because halogen costs 10,000 now. Cost is also an issue.
Do you use the half that was, we all tried in between, or the full one halogen for each?
I use a full halogen circular, the 2 6mm circles.
Your comment, Swathi, do you use halogens as well?
Yes,
or?
Yes, sir. So on young patients who are myopes, so where we can't have any chance of hypotony, or you just want to be safe. So I'm sorry, sir. 1 minute.
Sorry, I'll just continue in the meantime. There's one more thing that I use halogen for. When I revise a trab, an old trab,
total bleb revision.
Total bleb revision.
Not the needling one, the bleb revision.
Not the needling one. It's an incisional bleb revision. I would prefer to use halogen and close it up. In fact, off late for even a hypertonic bleb when I'm revising, instead of this scleral patch, I use an halogen. It's you just put it on top of that. Old mito trap, there's almost no flap left there when you open up. You just put halogen on top and bring in fresh conjunctiva on top of it. It works very well.
Dr. Ajith, your experience with mitomycin versus halogen?
I use mitomycin more often than halogen. Halogen I use in high myopes who need a trap, sir.
Where you don't use mitomycin?
Yes, where I don't use mitomycin.
Sorry, I'm back, sir.
No problem.
So, can I continue?
Yeah, please.
So we use halogen for, as I said, sir, young patients where we can't afford to have hypotony, or mostly myopes we use, sir. And also young patients, and we do a superior nasal trap first. Keep the superior temporal part free. So we all do a superior nasal trap only, and then temporal phaco, like that. Or if it's just a trabeculectomy, supranasal. So at least our superior temporal part is having virgin conjunctiva, possible for a trab or a tube later on.
You say young patients, is it, what would be the age group like? Would it be the pediatric age or no?
No, ma'am. So it will be like juvenile open angle glaucoma patients.
Yes, okay. Yeah.
Basically, where you expect a long-term hypertony, 1 year down the line, it'll go in hypertony. In younger patients, and especially if it's a young myope, when we do a trab with mitomycin, that's the issue.
Yeah.
Okay, I think we will slowly wind up this session. It's been a great 1 hour talking about MIGS and some questions regarding incisional glaucoma surgery as well. I thank Dr. Swathi, Dr. Ajith, Dr. Thomas George for their wonderful comments. We have also kept to time. And I think as closing remarks, I would like to mention 2-3 points. One is the lack of predictability of a routine filtering surgery, and that is why we have alternate procedures like the MIGS. But as yet, the MIGS has not totally replaced filtering surgery. It has got its own position. The tube shunts also have its own position in the glaucoma armamentarium. But the future will tell us which are the MIGS that is going to stand the test of time in India, which are the ones that are going to be cost effective and affordable for our scenario. And over maybe next 5 years, Swathi will accumulate enough evidence to tell us which is the procedure that is going to stand the test of time. So thank you once again, and I hand over the proceeding to Dr. Suresh Babu, who will take over and go ahead with the session on pediatric glaucoma.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir. Thank you.
Bye.
Thank you. Thank you.
Thank you, Sai.
Unmute. Stephanie, unmute. Unmute.
Yes, sir. Yes, sir. Sorry, sir. Thank you, Dr. Saikumar and all acclaimed panelists for that very instructive yet comprehensive session. We come to the final installment in our CME series, which is Pediatric Glaucoma, an Overview. To chair and moderate this session, I humbly welcome Dr. Thomas George, Senior Consultant, Chaitanya Eye Hospital, Trivandrum. On completing his postgraduate studies, Dr. Thomas worked as a tutor in ophthalmology at CMC Vellore. He also worked at the Shiflin Leprosy Research and Training Center, Karigiri, Vellore, after which he joined the Faculty of Government Medical Allopy and the Regional Institute of Ophthalmology, Trivandrum, in that order. In KSOS, he acted as a website editor for KSOS at a crucial period. He was also the Joint Secretary KSOS and was nominated as a member of the Scientific Committee for KSOS. Over to you, sir.
Thomas, unmute.
Okay. Good afternoon, everybody. Welcome to the session on pediatric ophthalmology and pediatric glaucoma. And as our keynote speaker, we have none other than Dr. Susmitha Kaushik. To describe her CV is quite a long thing. I think I'll use up most of the time here. She completed her ophthalmology training from Maulana Azad Medical College, Delhi, senior residency and research officer in PGI, Chandigarh. And since 2004, she's been the faculty there. She's a professor there right now. Her research interests are newer diagnostic tools and notably childhood glaucoma, angle closure, and glaucoma surgery. And she has a lot of publications, has contributed a lot of chapters to a lot of textbooks, and she has authored the educational module on primary congenital glaucoma for the WGA, World Glaucoma Association, for this year. And she has been a speaker in multiple fora all over the place, all over the world, you would say. And she was the founder secretary of the Indian Pediatric Glaucoma Society and a former secretary of the Glaucoma Society of India. She is a co-author for the consensus on childhood glaucoma and WGA, a nominated member of the Glaucoma Advisory Board of FACO AIOS, and in charge of academic program and advanced eye care in PGI Chandigarh. She has many honors to her credit. She's the invited member to the World Childhood Glaucoma Research Network, invited member to Task Force of the Ministry of Health for Glaucoma, and awards go on and on and on. And she loves all sorts of extracurricular activities, being music, be it arts, whatever. And personally, I find her a great human being to interact with. Over to you, Susmitha, to give us your keynote
Thank you
address.
so much, Dr. George, and thank you, everybody at Kerala. I'd like to share that Kerala is always holds a special place in my heart because the best part of my childhood was spent in Trivandrum. Between I was, I think, 8 to 13 years, and it was wonderful there. My parents were in Sri Chitra, so my journey with life actually started in Holy Angels Convent in Trivandrum. So I'm very, very happy to be here with you, and humbled by all that Dr. Thomas has said. When you have good friends introducing you, they go overboard. But thank you so much, Thomas. So I would be speaking today on an overview of the management of pediatric glaucomas. It's been a humbling journey for us because we've now realized how little we knew, how little we know, and how much there is to learn before we even think of doing justice to these children. There are no financial disclosures. I usually show a lot of photographs and I take consent from the parents to use their clinical photographs for academic purposes. So the journey started when I realized that the magnitude of childhood blindness is quite a bit. And this is defined as a best corrected visual acuity of less than 360 in a child less than 16 years. The prevalence is about 0.1 to 1.1 every 1,000 children in the world. And in India, it's about 0.5 upon 1,000. So why bother? Though the numbers are less, glaucoma is the second largest cause of blind person years following cataract, and the number blind into number of years a person lives with the disease. So approximately 40% of childhood blindness is avoidable, and a large chunk of that would be taken up by glaucoma because it's something that we can treat in time, along with, of course, ROP. So the worldwide recognition of the importance was relatively recent, surprisingly. It was only in 2013 that the World Glaucoma Congress stood up to the fact and woke up to the fact that childhood glaucoma is a problem. And it's only here that we had a consensus guideline. So that's not too long ago. And I was fortunate to be part of the CGRN, that's Professor Peng Kho, Franz Gren. And the idea from the UK PGS actually spurred us on to formulate now the Indian Pediatric Glaucoma Society. As you can see, there are lots of women, and I think it takes a mother to know to touch one mother's heart when they see a child who is not doing well. So it's interesting worldwide the number of women who are actually pediatric glaucoma specialists. So what is the main challenge that we have? It is a potentially blinding condition, but our job doesn't end with IOP control. So this is one glaucoma which is really, really taxing. And preserving their long-term vision is the real challenge. So for instance, this newborn glaucoma comes to you and then the periphery clears, but the central cornea is scarred. And then she lands up with a bilateral OPK. But then this journey is going to carry on for the rest of their life. So you have to push your cornea colleagues, you have to push your cataract colleagues and say that this is my baby and you need to do it early. And of course, I don't need to emphasize what happens if they're not treated, because a lot of these babies will land up like this girl who actually came to us when she was almost blind. And even though we did something for the left eye and gave her ambulatory vision, you can see the right is nearly gone. So the challenges that we have is it's difficult to examine. We don't know what they have. It's a surgical disease and surgery is difficult in these tiny elastic eyes. The post-operative follow-up requires repeated general anesthesia. And like I said, the one glaucoma where the goal is not target IOP, but target vision. And there are complex problems because it's not an eye that we're treating, it's a whole family. There are genetics, there are other siblings, and then of course, there's the life of the child itself. So coming to difficult to examine. Actually, this is one of my favorite slides, which we put together a long time ago. We can do a lot with these children. These 2- and 3-year-olds are allowing Goldman applanation, gonioscopy, 90D examination. And by the time they're about 5 years old, we start putting them on the visual field. And you'll be surprised at the dexterity that these children have, probably with the dexterity with mobile games and video games, how well they actually adapt and learn to do visual field. So we don't give up on them and we start as early as we can. They're fun to work with. Visual acuity assessment is also a game that they love to play. This is something that I've used very often with small children because there's no way I could examine all of them, is just a good quality photograph camera, and I photograph each one of them. And each one, you'll be seeing a lot of pictures which are from this camera, which is what really tells me what it has. And I've learned that phenotyping these children is so important rather than just put them all into one basket of childhood glaucoma. So childhood glaucoma, as you can see, is a potpourri of many, many conditions, from the innocuous primary congenital glaucoma, which behaves like this when you operate early, to Sturge-Weber, to microspherophakia, to Axenfeld, steroid responders, and the works. So you have a potpourri of many, many diseases. So just to put it in perspective, in 2013, the Childhood Glaucoma Research Network got together so that everybody is talking about the same thing. And that has really furthered the management of these children ever since. So primary childhood glaucoma is a glaucoma which has only a trabecular dysgenesis. So the main ones are primary congenital glaucoma, PCG. So PCG means there is nothing else. There's no iris atrophy, there's no iridia, there's nothing else in the eye except a trabecular dysgenesis. This could be neonatal onset and late onset, and of course another infantile, because the onset also determines how well they do. The other primary childhood glaucoma is a juvenile open angle glaucoma, defined as pressures between glaucoma presenting between 3 and 40 years of age. So what is the late onset? So it was decided that if you have ophthalmos in a child who's presenting, say, at 6 years of age, it's probably late onset PCG, because the pressures must have been high before the age was 3 years to allow the eye to grow. On the other hand, if you have a 6-year-old child with raised pressures but no other features of PCG, such as no harbs, no limbal stretching, you assume that the pressures must have been elevated later, and this child probably has an early JOAG. So, but then that's why JOAG has been clubbed into childhood glaucomas, because you have a lot of 10 and 12-year-olds which could be classified as JOAG. And then comes the whole gamut of secondary glaucomas. So one is a non-acquired ocular anomaly, which means that it's nothing from external, and all other non-acquired would include Axenfeld, aniridia, Peters, etc. Non-acquired systemic disease, Sturge-Weber, neurofibromatosis, the other things, again non-acquired. Then acquired conditions, steroid, trauma, intraocular surgery, and following cataract surgery has been given a completely separate group, simply because glaucoma following pediatric cataract surgery is something that we need to look for in every child who is operated for cataract. So why is knowing what they have important? Because all of them present with a cloudy cornea. So this, for instance, is an acute hydrops. If you recognize this in time, because this will come with, the mother will be distraught and say that he was fine 2 days ago and look what happened today. And if you just intervene in time, they actually clear well and he's almost normal. There's neonatal onset congenital ectropion uvea. This is what it looks like. This is what we've described as a distinct phenotype of newborn glaucoma. Very, very intractable. The CYP1B1 keratopathy is very common in them. The corneas may not clear, and important to prognosticate to a parent that, look, this is a really, really intractable glaucoma that he has. Congenital primary aphakia, again, we've learned to recognize this. This is a silvery hue on the cornea with large ophthalmos, and we made the mistake of operating this. And remember, it's a global developmental problem, including the ciliary body. If you're going to intervene, it lands up in phthisis. It's only after we did this child that we started to actually recognize this condition as well. Rubella, it's a neglected manifestation. Glaucoma is a neglected manifestation. If you see this large, broad forehead, triangular face, and if you have access to a UBM, if you see a cataract, it's so important, because then we've picked up PDA, we've picked up sensory neural deafness. So it's a global congenital rubella syndrome, which happens to come to you simply because the child has cloudy corneas. If you're going to lump this as PCG, you're not going to be doing what is best for the child as we should. So it's important to recognize the problem. So who has childhood glaucoma? How does the angle develop? How do we recognize angle dysgenesis? How do we know that this is angle dysgenesis and PCG? Why does anterior segment dysgenesis happen? How early can it develop? What options do we have? And after you manage, what next? So who has childhood glaucoma? Again, is the CGRN classification of that. It says at least 2 of the following criteria: intraocular pressure more than 21, optic disc change, corneal findings, progressive myopia, or in older children, a reproducible field defect. Now, intraocular pressure has been given investigator discretion because it's required for children under general anesthesia, and there are variable effects of anesthesia on IOP measurement. But this simply means that if you record a pressure of more than 21, it falls into the criteria of childhood glaucoma, regardless of what anesthesia, what measurement, and what you do. So we've also seen that it's like an ocean. It's similar on the surface, all right, but there are countless myriad hues within, and we're all kinds of babies that come to us once we really get to identifying them. So we've gone through this. So once we've diagnosed, it's important to put them into one basket. And I've just listed out for the sake of completing what all are the things that falls into each of these. So you've seen this primary congenital glaucoma. If it's 0 to 1 month, it's neonatal onset. If it's 1 to 24 months, it's infantile. If it's late onset or recognized after 2 years, it's late onset PCG. And if there is no ophthalmos, JOAG. So these are the acquired glaucomas, and these are the secondary glaucomas acquired after cataract surgery. So these are the ones which most commonly come to the glaucoma person who have a problem, who come very, very late. These are the ones which usually would have a history and are relatively easier to diagnose. So then what is angle dysgenesis? So this is what an infantile angle looks like. A flat iris insertion, the ciliary body band is generally present here. The stroma is not very well formed. And the iris, there's a major arterial circle, if you can make this out. And there are radial iris vascular pillars. Now, this is from a patient of congenital cataract who was going to be done. And I thought I would just, let me just look at what a normal angle should look like. So for babies, EUA, a direct indirect gonioscopy is important. This is what a direct gonioscopy looks like. So this is on table just before surgery. Every child would undergo gonioscopy. This is a Schwann-Jacob lens. You just gently put it on the cornea. You could probably use a small film of viscoelastic to do that. And it's easy to see the angle once we do. So this is what a normal angle development is like. At 5 months, it's a continuous layer of endothelium. In the 3rd trimester, the endothelial layer progressively disappears. And there's continuous development till 1 year of age. So that's the important thing to understand. So in PCG, it may be arrested anywhere. It may be arrested here. It may be arrested here. It may be arrested far back, and this is where it is normal. But this carries on till about a year of age. It's important to understand this because it might explain why congenital cataracts operated less than 6 months of age, or the non-lens sparing vitrectomies for ROP are the ones which develop the intractable glaucomas. And probably it's because the insult, the surgical insult, is happening in a non-mature trabecular meshwork. And if you can manage to wait a little bit till they're about 7 or 8 months old, I sort of think that the glaucoma might be prevented a little bit if we do that. So these are the development of outflow channels. So here by 36 weeks, which is term, you have the long and short longitudinal trabecular meshwork fibers, and the pores develop only at 36 to 40 weeks. But the outflow channels develop later. So that again should give you an idea of why neonatal onset glaucomas do badly to angle surgery. Because even if you take off this trabecular meshwork, the outflow channels have not developed. So that could be one reason why infants less than 1 month of age don't do very well with angle surgery. And the best infants for angle surgery are the ones who are between 1 to 24 months, where the outflow channels start developing. So this is neonatal onset and this is the infantile onset. And I tend to think that that's the reason why the infantile onset would actually do better. So coming to the pathological angle, this we've seen what the normal angle is. This is a type 1 angle. Now, if there's a wonderful book by Sam Paolisi, who's actually given us a Bible of pediatric glaucoma, and he did hundreds and hundreds of goniotomies. And the question was why in the same surgeon, some goniotomies work and some don't. And then he went back to his drawings of the angle. He didn't even have photographs at the time. And these are photographs from our children based on the drawings from that book. And he actually described a type 1 angle where there is a high iris insertion. There are iris processes, and yet the trabecular meshwork is visible behind it. So if you just made a cleft here, this eye is likely to respond to an angle surgery alone. Whereas a type 2 angle has more severe goniodysgenesis. The iris is reaching right up to the Sam Paolisi's line, is just receded a little bit in places. And this is the sort of angle which he thought would not be amenable so much to glaucoma angle surgery. And he actually saw that these were the very early eyes, whereas these were the later eyes. So he called it a type 1 and a type 2 angle. So that's something else that we've learned to keep in mind when we're doing gonioscopy for these children. So what is anterior segment dysgenesis? So a lot of these terms are interchanged. So I thought I'll just put that into perspective. Congenital glaucoma, primary congenital glaucoma, anterior segment dysgenesis. So there's no such thing as mesodermal dysgenesis. Some of the older textbooks might say that, simply because the anterior segment, the iris, the corneal stroma, and the trabecular meshwork are neuroectodermal in origin and not mesodermal as was thought. So mesodermal dysgenesis is not a term that we use. What we use is anterior segment dysgenesis. It's a group of non-acquired ocular anomalies. Many genes are responsible for development of the ciliary body, lens, iris, and cornea. And that is why this entire spectrum of structures are affected in the anterior segment dysgenesis. And the abnormalities have a clinical classification and description which is difficult, but typically they include combinations of iris hypoplasia, ectopia pupil, iris holes, corneal opacity or glaucoma, and an angle dysgenesis. So these are the combinations and permutations of all of this which really give you a phenotype as to what this is. So various combinations, we'll just go through some of them. Peters anomaly. Now, Peters anomaly is defined as a central Descemet's defect with or without iridolenticular strand. So this is something which we see very often, and the UBM actually gets out the central Descemet's defect. Aniridia is a rudimentary iris and foveal aplasia. So sometimes aniridia, this is called the classic aniridia. This is an OCT which was done in the OR from the retina surgeon side, and you can see there's no foveal dip. So this is classic aniridia. This is important because it's likely to be PAC6, and if it's PAC6, it's very close to the WTR gene, so you need to look for Wilms tumor. Whereas Axenfeld, this is a spot diagnosis, wide telecanthus, flat nasal bridge, mandibular hypoplasia. She hasn't had teeth even though she's 8 months old now. This is a complete Schwab's line in this child. So sometimes it's usually a posterior embryotoxon, but sometimes the Schwab's line can be detached like this. So this is a complete Schwab's ring rather than an anterior most posterior embryotoxon. This is the correctopia. And these are the typical processes of an Axenfeld-Rieger. So this combination is really called an Axenfeld-Rieger syndrome. This is, of course, the neonatal onset CEU that we've described. You can see the iris epithelium is on the iris surface, and there's severe iris hypoplasia. And sometimes you can even see these blood vessels here because there's so much of stromal hypoplasia that these are normal iris vessels. We've also made the mistake of calling this actually a neovascular glaucoma because there's ectropion and there are vessels visible, and we had no idea what we were dealing with until we understood that this is simply a severe iris hypoplasia giving rise to this condition. So the UBM is, of course, invaluable. I'm just sharing some pictures. Its sine qua non is a Descemet's defect. Here is the diagrammatic picture. And these are the ones with the iris strands, which will do badly. And these are the ones where the iris is not stuck and they do better. And you can see they come like this, and we've actually published this corneal cleft. Now, this is something else that we've learned, that actually within the cornea, there can be so much of edema that there's a huge corneal cleft. And then after surgery, you can see that this eye has cleared in the periphery, and the actual Descemet's defect is this tiny thing. So this huge thing was actually just fluid filled in the cornea, which resolves after surgery, and this can be now amenable to optical iridectomy until you're awaiting your OPK. The clinical clue is this central clear cornea within a corneal edema. So this is where the photographs matter. These are all pictures in the clinic. You just put in an infant speculum. You're a little hard-hearted because the children yell a bit, but that's okay. It takes about a minute to just photograph them. And then we know on EUA to expect a Descemet's defect, and we get the UBM in, and sure enough, we see that. So this is Axenfeld we've talked about. These are the characteristic features. Sometimes the iris might be really almost rudimentary, and the redundant umbilical skin is a giveaway. We've also diagnosed ventral hernias, and we've had little babies operated for their ventral hernias. And the pediatric surgeons have been very happy because most of them otherwise come with an intersusception or something. So Axenfeld, remember, runs in families because FOXC1, which is the gene, is autosomal dominant. And this is 3 generations. The grandfather is blind. The father has very low vision, blind in one eye, very low in one. But they got their daughter in while she still had 6/12 vision in both eyes, and we hope to preserve that. This is another mother and child with Axenfeld. You can see the same sort of facies in both of them. So Axenfeld and aniridia run in families. Aniridia is another one, another autosomal dominant, father, son, and a younger brother, all have PAX6. So this is what we were talking about. If you have a PAX6 variant, the WT1 gene is very, very close to the PAX6, which is why Wilms tumor happens, which is why genetics is important, because if you see classic aniridia with PAX6, that is the one which is going to require surveillance. But if an aniridia is not classic, sometimes you can have FOXY1 aniridia, then you don't need to really put them under surveillance. The other clue for a PAX6 is they usually have nystagmus, they have a superior subluxation, and they have poor vision. And also, of course, they have aniridia keratopathy because there is congenital limbal stem cell deficiency. So these are all PAX6 aniridias, which is a phenotype to understand when children come to you. So this is the novel phenotype. We've just gone through that. The preliminary data, we've seen that it is CYP1B1 associated with one particular variant, which is arginine 390H, which means histidine is substituting arginine at the 390 position. Almost all our children had that. Another thing is this, sometimes this is diagnosed actually as aniridia. And Professor Arif Khan actually called it a partial aniridia. But if you look closely, the rudimentary iris does have ectropion UVA, and all of these come out to be CYP1B1 and not PAX6. So coming to our story of congenital primary aphakia, it's characterized by the absence of the lens and failure of lens induction from the surface ectoderm, aborted lens development, and histologically total aplasia of the anterior segment, almost always associated with the FOXE3 gene. If we don't, now you can see this, that even the corneal stroma and the trabecular meshwork, and there's no lens, and that's the way we identify them. So this is clinically, we've shown these large lenses, this silvery blue shiny hue of the cornea. The lesson to be learned is don't ever operate on them. So recognize it, no incisional surgery, IOP reduction if required by very limited TSCPC under transillumination. So you can see under transillumination how far back the ciliary body is. So if you're not going to transilluminate them, this is just a pen torch. Just put it close to the cornea, the ciliary body lights up and we mark it, and then the DLCP is done. If we don't do that, a lot of the DLCPs would be done in the sclera. You're just causing a lot of inflammation, but nothing at all. And then we say the DLCP has failed. So what they need is +10 glasses. This is a baby who we didn't know better, and we went ahead and did surgery, went into phthisis within 4 weeks of surgery. But with +10 glasses, he's now ambulatory. So all these children love their glasses and they won't let you take them off. And that's all that they really need. So why is just knowing the phenotype not enough? Because the genotype is so blended amongst each other. So if I just say a primary congenital glaucoma, Axenfeld, Peters, iris hypoplasia, aniridia, and CPA, which is about 70% of all the developmental or 80% of all the developmental glaucomas that come. You can see the features are all plus minus in each one of them. So there's no set pattern as to what the features will be in each. So deep phenotyping is so important to understand what you're dealing with and then tailor your management according to what the baby has. So again, a greater understanding of the molecular basis. We've seen that this is just an overview of what we have. Since we've got clinical exome sequencing now at an affordable cost, we've started sending it. So we have it on our tips, and now all our residents also know what PAX6 aniridia means and what FOXY1 aniridia means and what CPA we should look for. So once we start to do it, it's easy, and genetics itself gives us a lot of information and clues as to a better monitoring. So this is the same thing. I'll just skip that. Okay, so where does genetics come in? So this is a critical first step in the development of gene-based diagnostic and screening tests. The first thing. So if we knew at this time, and if we could just do a blood test and see that she's FOXY1 autosomal dominant, we'd have told her, look, you have a 50% chance of a child having very intractable glaucoma because of Axenfeld like you. So think about it. So at least we could give that sort of counseling. This family, for instance, so this is this lady's brother. His children have glaucoma. These two have glaucoma. It's a whole family which is affected. with the same variant. If somehow we could have screened this family and we could have told them, we could have somehow maybe not had so many children with glaucoma coming into the world. So it's crucial for genetic counseling and risk stratification for secondary or later pregnancies. But then it's not so simple. There are the mixed phenotypes. So you have Axenfeld in one eye and Peters in the other. Both can be caused by a PTX2 mutation. So that PTX2 mutation has caused a Peters in one eye and an Axenfeld. Similarly, this has caused a PCG in one eye and a Peters abnormality in the other. So it's not tried and tested, and it's not watertight either. But then that's how nature is, I suppose. So these are non-acquired childhood glaucomas and systemic conditions. Sturge-Weber is one which we've learned. The important thing is to do an indirect of both. So this is under the microscope. You can see the difference in the glow. This baby has Sturge-Weber, has port wine on one side. You can see blood in the Schlemm's canal on gonioscopy, and you can see how red this glow is, which means there's choroidal hemangioma. So this is, of course, episcleral hemangioma. Again, choroidal hemangioma seen on indirect. This is just a fundus photo, but you can see this sketchup. If you saw this in isolation, you would probably say this fundus is normal and there is no choroidal hemangioma. Remember, in Sturge-Weber, it's a diffuse choroidal hemangioma, and you're not going to see an orange circumscribed choroidal hemangioma as is classically described. So look at both of them. We've learned the PPV, the phacomatosis pigmentovascularis. We never used to hold up the shirt and see, but sometimes the melanosis is so stark that you would have missed the nevus of Ota diagnosis. And this you have to send to a pediatric neurologist, because a lot of them throw seizures once you give them general anesthesia. So that's something that we've learned as well. Don't forget infections. We've seen a lot of, so once the cornea clears, you can suddenly, to your horror, see these cataracts. And that's when we started doing UBM in all our children with cloudy corneas. And we can see, once we see this cataract, it's almost certain that we're dealing with congenital rubella syndrome, which we now know is a pan disease, a pan body disease, and so many organs can be affected. So just to give you an idea, we looked at our new patients from Jan to December 2019, just to get a clue of what are the new patients that come to us. These are children which have come to us in 1 year for the first time. So out of the 618 children that were referred to us with glaucoma, 277 were suspects, didn't have glaucoma at least at presentation. But 341 in the whole year, almost one new child a day had glaucoma. 30% were PCG, 7% JOAG, 11% were actually anterior segment dysgenesis, 3% with non-acquired. But look at this. Most of this was steroid and trauma, 32%. So 1/3 PCG and 1/3 steroid and trauma. So that gave us an essence of how much we actually were seeing in children. 5.9%, my take is these are the glaucomas that came to us. And I suspect if we looked at every child who had undergone cataract surgery, these numbers would be more. But these are those who came to us with the obvious 0.9 cup 40 pressure glaucomas, which weren't there before. So they weren't looked for. UBM is an asset. I've already shown that. So we'll just skip this. Now, how it aids in clinical diagnosis, for instance, this girl. Now you wonder what to do. So this bilateral Peters, this has no iridocorneal contact centrally, only peripheral. This one has iridocorneal contact and also a cataract. So you can tell the cornea surgeon that, look, I'm going to do the OI now. Her vision is now 624. So whenever you do the PK, you be careful of this eye. I would prefer you do this one first. So it aids in what you do. I would never even attempt an optical iridectomy in an eye like this. In any case, the cornea, there's nothing clear there. So these are just examples of how we use it. Coming to surgery, the initial surgery varies. PCG, developmental glaucoma, we've just said, usually goniotomy, trabeculectomy. If I can't see the angle, I would do a combined trab with trab. Acquired glaucomas, usually a trab with MMC is what we do. Just a bit about goniotomy. There are angle surgeries is the preferred first options. We've seen that we need to visualize the angle. This is how we visualize it. It's usually there, the CV body band. These are the type 1 and type 2. We've seen that. So the principle is an ab interno slicing the non-functional trabecular meshwork, providing a conduit for the aqueous to go out into the outflow channels. What do we need? We need a surgical gonio lens. We found that the Swan Jacob works the best in terms of resolution and visibility, but you have something called the Mori upright, where you don't need to tilt the microscope. You have a rich lens which is cut in the center. So the instruments that go in are more under visualization. And you also have an Abraham's lens with one mirror, which you can use. But we found the Swan Jacob to be the best. So the microscope is tilted, the head is tilted to the opposite side so that the angle is straight in your view, and the surgeon sits directly opposite the angle to be operated. So this is the Zeiss microscope that we have. I'm sure the other models would have a tilt, but you need a microscope which has a tilt. So we tilt it, each eye and each nose and each baby is different. So there's no set pattern as to how much you need to tilt it. I've just shown you how we tilt the head, the opposite side. So the microscope is towards us, and we gently put the gonioscope on the cornea. So, sorry. Yeah, so we put the gonioscope on the cornea gently, and this is usually under viscoelastic. We use sodium hyaluronate, which spreads easier and keeps it there, and that's when we see it through. So this is probably, I just pulled out the first goniotomy that we did with a lot of, so we used the rich lens at that time because I was so scared of not being able to see my instrument in. So I don't know whether I can move it further, but so this is in real time and very, very tentative. And but even with the first one, you could see the eureka moment of the cleft being formed and the iris going back. So once we saw that, but there's a lot of bleeding because the tip was that you don't have to feel the tissue. You need to just see the tissue. And here I was trying to cut it and feel it. So this is a typical novice goniotomy where we know better now. This is what the disc is like, which we see through the gonio mirror. But even with this novice, we did the other eye in a week. At 18 months, the pressures are 10 and 12, and a vision is 6-9. So even with your first goniotomies, maybe you got lucky, but it's an easy enough procedure if you're doing gonioscopies and you're doing intraocular surgeries. It's not such a problem. Sometimes even if a CTT, so we planned a combined trab with trab in this one, and by now we were a little more confident. And if you can see the angle, now you can see the cleft being formed, and you see the difference is that you're just seeing it. You're not cutting it, and this is maybe a couple of months down the line. And you can see the cleft forming there, even though it's hazy. If I can, there you are, that's the cleft being formed. So even if it's a hazy cornea, and lo and behold, this eye also cleared. So goniotomy, sometimes under the microscope, here is that large cleft being formed. You can see it, and it is possible. One was not enough. We treated the remaining angle. We went in, and at 3 years, she's actually 6'6" both eyes with just a goniotomy, thankfully, and we didn't require a CTT. So what if we did it after the trab fails, but the cornea is reasonable? We've tried it in that also. So after a CTT, if it clears a bit, but not enough, and then a goniotomy is possible. So this was the hazy cornea before, and we went on and okay. So in any case, we did the goniotomy and the cornea clears. So as I said, it's not so difficult to do it, even if the cornea is a little hazy. That was the sodium hyaluronate or the cohibis that we say is on the cornea. And then you go in, and when if you can just see where the iris is inserted into the sclera, it's good enough to do. So you just put in your gonio lens. So this is again rich so that I could see the MVR blade or the knife. And then you can just about slice. So there's nothing much to the surgery except once you get the angle and you get the tilt correct, it's easy to do. They're a little scared, but yeah. So once you get the slicing and the iris falls back, you know that you formed a cleft. So even post CTT, we call it a secondary goniotomy. And the best thing to do with an acute hydrops, of course, is a trab with trab because you can't do anything. But the other eye, we did a goniotomy because it had a high iris insertion. And 1 month post-op, you can see the left eye is completely quiet, but the right eye is still congested with the bleb. So this is on the same sitting, goniotomy in one eye and CTT in the other. But this one still has a congested bleb, whereas this eye is completely quiet. So that's the difference. It's worked so far. This boy is now 4 years old, going to school, naughty as hell, but otherwise normal. So the other variations are a needle on a viscoelastic syringe, and the eye is rotated to treat 180 to 200. So we become a little more bold. So apart from the 120, now the senior resident just rotates the eye so that we do manage to treat at least 180 to 200 degrees. And this is a viscoelastic that has gone in, that's pilocarpine, which has constricted it. A lot of these under general anesthesia seem to dilate. And here is a syringe, a 25 gauge syringe on a visco cannula. The advantage of that is the assistant can keep pushing in visco so that you don't have to keep going in and out. So here it's going, and you can see that that's a cleft form, and the iris has fallen back. And similarly on the other side. And now you'll see that I've reached the end, and I'll ask my senior resident to rotate. And soon the eye would be rotated. That white thing that you see is the back of the Schlemm's canal. And as it goes on, the eye is rotated, and you can actually go up to about 200 degrees also. So treat as much of the angle. So that's the cleft you can see that's forming. I don't know if I can forward this a bit. Yeah, so I've reached the end, and now if you just watch, I'd say rotate, and the eye would be rotated. So it's the end, and once the eye is rotated, I can then, so I've reached the end here. And this is about, say, 120 or 130 degrees without rotation. And there comes the forceps here somewhere. And the eye is going to be rotated like that, so that I can go another 15 degrees or so and treat almost till 200 degrees. So this has been very, very useful for us. We've expanded the indications for JOAG, steroid-induced and uveitic glaucomas, thinking that the outflows would be all right, and the trabecular meshwork is the one. 6 millimeters of mercury on no drugs of a JOAG, it was 32 millimeters, settled down to about 12 or 13 millimeters later, but that's only 6 months. So far, so good. But this is a trabeculectomy actually, so an extension of the goniotomy. And so you can expand it to, so this is the pre-op and this is the operated angle. So our journey of PCG, one surgery was enough in 53% of the eyes. So that was very, very good. And in 84 out of them, 80% of PCG, one surgery was enough, but 53% in non-PCG, also one surgery was enough. So if you can avoid a combined trab with trab in 3/4 of PCG and half of non-PCG, I think that was very, very satisfying for us. So these are just details from this paper. Of course, when the cornea is very hazy, you need to do a combined trab with trab. It's a short clip of a 16 millimeters cornea. And of course, I'm sure most of you would have seen the principles of a combined trab with trab. Yeah, I can't seem to forward this anyway. So the challenge is the scleral flap, of course, in very, very thin eyes. So once the flap is done, you just cut across the white and blue, and slowly as it is cut in, this is the Schlemm's, the scleral spur that you'll see, the parallel fibers. And the clue is that the Schlemm's canal is just anterior to the scleral spur. So I make a cruciate incision, so it's easy for the trabeculectomy to get in. And this is the Harm's trabeculectomy, and it goes in easily. The outer one is my guide, and then we zoom down to see where it's going. And here it is. And once it reaches the complete Harm's trabeculectomy, it just comes in. So it's extremely gratifying for acute hydrops, for neonatal onset glaucomas. These children are going to school now. But what after surgical management? So once surgery is done, when do you call back? How to evaluate? What are disease progressors? So when is the eye patch open? Nowadays, COVID has taught us to do bilateral surgery, and we do that. If it's bilateral, 3 to 4 hours after GA, we open both, otherwise the baby gets to be very annoyed. And you can see even 3 hours after surgery, this hazy cornea has become a little clearer. And despite of this being post-op, the baby was more photophobic pre-op than post-op. So that's interesting that this is the, of course, speculum that we must have. So we look for cornea, AC, hyphema, will direct the next step, steroid antibiotics for 3 to 4 weeks. What next? Most important to look for the child's comfort and the mother's feedback. So this was what she was like pre-op, crying all the time. Post-op, she wanted to look at me through the slit lamp. The corneal clarity, IOP if possible, we now have the eye care. And what is very, very important to us now is the axial length. So the IOP, the rebound tonometer, you can see this baby in the mother's lap, perfectly fine, wondering what I'm doing, but then they let me take pressure, so that's easy. But remember that the rebound always overestimates IOP, which is good. So if the pressure is okay with rebound, I presume it will be okay by Perkins or CAT. So sometimes the IOP is normal and the axial length change is important, not normal value. So this, for instance, is post ROP. And you can see we plotted on that same Sampoulos' graph, which is an amazing normative growth. Every child in our clinic has axial lengths plotted. And you can see when the child came and by the time they got fit for GA itself, the axial length went like that. And the slope kept going up. The left is the blue and the right is the red. And then we did the CTT here and actually the axial length stabilizes. So even if the pressures are normal, sometimes if the axial length is continuously increasing, we did the surgery because despite normal pressures throughout this period, the axial length was beyond the slope of the eye and we knew something was happening. So this is what she is now when the CTT has cleared her cornea a little bit, and some of them actually come back also. They come down because they're so elastic, but she remains stable and she remains stable now. So when would we start? Of course, if the pressures are high, if the axial length is continuously rising, but it's very, very dangerous, look for this. This is an indication for EUA, suture removal, post-goniotomy, very, very important. During COVID, I must confess, I've lost one eye to endophthalmitis simply because they couldn't come back to us. And there was a corneal melt because the child rubbed the eye so much. So these are humbling and sobering things that we need to keep in mind. So these are what we look for usually 4 to 6 weeks later. We recognize the risks of repeated general anesthesia. We've published this. You can go through this paper. This is an easy thing that comes. It's called atomizer. It atomizes a drug and squirts it in as a spray. And we've used dexmedetomidine. And a lot of the children who require post-operative reassessment of the pressures, if you're suspicious, we do it under sedation and we don't need to give them general anesthesia. So now, even if all this is done, is our job done? So beyond the IOP, don't forget vision, retinoscopy, visual acuity, visual assessment, amblyopia, and of course, visual fields later. There's so much beyond the IOP. We are in the business of vision. We keep doing a lot of optical iridectomies. Contact lenses are a problem after glaucoma surgery. If you have a large bleb and she's unilateral myope, the contact lens you'll see in a bit will just pop out. So the minute she looks up and down, this little girl, the contact lens pops out. So what we've also done is something which I don't like, but we've done this refractive lens exchange. This boy was minus 22 in one eye. There was no way that he was going to see very much. We pushed the cataract surgeons to put in, do a clear lens extraction, and they actually had to put in a -4 diopter IOL. So this boy with a -4 diopter IOL in place, with a little bit of reminiscent myopia still remaining, finally regained about 6/9 vision, where he was just 660 and going into esotropia as well. So even if the IOP is controlled, cornea is clear, this is the boy who we did all that. And then we have preterms. These are 25 weekers, 780 grams, PCG, temporal avascular retina. We were scared first, but then I thought to myself that if I had a 30-weeker or if I had a term baby, I wouldn't wait for 2 months to do the surgery. So if the GA and the neonatologist clear, then we've started doing preterms now, and we are so happy that by the time they're actually term gestational, their corneas are clear and we do better. So it's a matter of just being a little brave and going ahead and doing what we have to. Word of caution, sometimes no glaucoma treatment is required. This is sclerocornea, this is retinoblastoma, this is Cruzons, not ophthalmos, and this is hydrocephalus with a very pale disc and non-glaucomatous cupping. So these are examples of children who've been referred who don't require glaucoma. So childhood glaucoma is a lifelong disease as all other glaucomas and can manifest in myriad forms, multiple etiologies. So much is unknown. Ensuring good vision, I think, is our goal, not IOP control. But remember, we need to hold these babies' hands for a long, long time. Thank you. Thanks for having me again.
That is a wonderful talk, Dr. Susmitha.
Thank you
Nina,
so much. I don't know how to stop sharing. Okay, yeah. All right. Yeah.
that is a wonderful talk. Even I am
Thank
learning
you.
a lot more. I mean, I'll
Thank
have to
you.
revise this talk on the YouTube tomorrow to
Yeah,
understand
yeah,
everything.
please.
Quite
Thank
a bit of info there.
Yeah.
Nina, what's your take on the talk itself?
Yeah, truly enlightening, sir. I was really very happy to be here today because I think ma'am has explained wonderfully how we should approach pediatric glaucoma as a stepwise approach. What are the investigations that we should do? So much information I gathered too, because I'm basically a pediatric ophthalmologist and I do follow up these kids. So I'm definitely enriched by the talk.
Thank you. Thank you so much. Axial
I
length
have
is
just
something
one
we
doubt to, I have a doubt to ask because what's your take on the IOP criteria for these kids? So is there any absolute IOP level beyond which you say this is glaucoma, starting from a neonate to an infant to a juvenile?
No, because IOP, in fact, an EUA in the IOP is right at the bottom where we are concerned. So even if the IOP is 10 and the child has got half strike, it's glaucoma. If the IOP is 14 and the child has nothing else and no limbal stretching and the disc is fine, it's not glaucoma. So it is said that the normal IOP in a neonate is between 10 and 14 millimeters. But that's normal IOP in a normal neonate with a normal cornea. We are not talking of an IOP in a cornea which is so edematous that has so many corneal clefts where the pressure is simply not being recorded. So I think it's a lot of surrogate. We use axial length, we use corneal diameters, we use the cornea itself, the clouding, much more than we would use an IOP. We would use IOP only as a measure of something to look forward to. In fact, there are times when at presentation on EUA, the resident will come and say, ma'am, the pressure was 12 when we started with, and now it is risen to 15. I said, no, because the corneal diameter was 940 with that, and now it is 500 and something. So you see the UVM, and that's why the IOP was higher, lower there. So it's and then of course there's anesthesia. So the effect of anesthesia is another problem. So that's why I think the CGRN, because they've taken children less than 18. So they've sort of just given that if the pressure is more than 21, then be very, very vigilant. It's certainly not going to be more than 21, but in a neonate, normally 10 to 14 is the pressure. And what we've seen is once we clear the corneas and they're so-called normal, they're usually in the mid-teens. They are never, if a pressure in a baby is going up to 18, 19 with a clear cornea, I would be very, very scared. But like I said, it's so many things together. So even if the pressure is say 17 and the axial length has become stable in a 6-month-old child, I'm okay with it. I would say, chalo, okay, let's hold on to him. So I don't,
ma'am, you have to connect the dots. I truly agree with you.
Wonderful talk, Dr. Susmitha. I am so sorry, my Wi-Fi network is going on and off. So really wonderful talk.
Thank you so much. Thank you, ma'am. Thank you so much.
I just wanted to know something after in FAK glaucoma. Actually, recently I had a child who was operated at 8 weeks, and the contact lens was given. Refractive error, refraction was 23, and we gave 20 diopter contact lens. Unilateral it was. Okay. And the child has come back after 3 weeks with a drop of 6 diopters of refractive myopic shift. So then I tried to, I did an IOP. There was an asymmetry, not very high IOP. It was 20, but axial length did not increase as expected, much more than the other eye. I put her on a disc, was very healthy. So I put her on some medication. I don't know this much whether it is due to the normal growth difference in cornea flattening and all the, I'm not sure whether it is still due to glaucoma or axial length seems to be okay, but 6 to 7 diopters of myopic shift in a month, 3 weeks to 1 month.
Why 6 to 7 diopters if there was no myopic shift? I mean, if there was no axial length increase? because
Axial
it's
length
FAK.
has increased by 1 millimeter, but it is the
1 millimeter
same.
only.
Yeah,
In
1
both eyes.
millimeter.
Yeah, actually, I think with these myopes, our pediatric ophthalmologists also, I take keratometries and axial lengths, and I don't understand refractions. Then you tell me, and they say there's so much that is unknown. We don't know
Yes.
with scleral expansion what is
We are
happening.
closely watching
Yeah.
the child, but
Yeah.
I don't
So
know
I think,
whether
ma'am,
this happens due to
axial
the
length,
corneal flattening. I don't know.
and
I've not taken the keratometry after this at that point.
Laila madam, was it a foldable lens?
no, FAK.
FAK.
Ma'am, one thing that I came across was
FAK
again very interesting, that the lens itself, the lens placode is a regulator for anterior segment distance. So that's the reason why if you take out the lens very early, the trabecular meshwork does not develop, which is why very early cataract surgeries leads to so much more glaucoma. And that's what drove the lens sparing vitrectomies also in ROP, and we've seen much less glaucoma with that. So just one little thing that we've learned also, that it has something to do with regulation. The same reason why congenital primary FAK also has glaucoma, because the lens placode hasn't been there to drive the rest of the anterior segment. So I would watch it very well. Yeah, sorry.
On that same note, there's one paper which said that the aphakic glaucoma is probably due to the fact that there is some, decrease in the size of the Schlemm's canal size post lensectomy, because the normal during the normal accommodative effort, there is some normal dilatation of the Schlemm's canal, and when you take out the lens, this doesn't happen, and probably that's the reason why aphakic glaucomas are happening.
There's an ASOCT paper on collapse of Schlemm's canal following early cataract surgery. So everybody is trying to figure that puzzle out. But I think the jury is out of the fact that very early lens extraction in a child somehow should make you more vigilant towards glaucoma, at least, and look at it closer than whatever.
Ma'am, are you using more of eye care now than Goldman applanation, Perkins? Because I wanted to know, we're going to buy a tonometer, and I'm doubting whether I should
you must buy both. Actually, Sirisha's paper actually looks at it, and they did an agreement, and they found that till about 19 millimeters, it agrees. But if you have, much like the NCT, the minute the NCT is more than 21, there's no point in looking at it. So my take is, if the eye care it's less than about 19, 18, then it's fine. Once it starts going above, then I always confirm with EUA. But it has made a world of difference. If the eye care is also okay, and the axial length is also within range, and the vision is also all right, and the myopia is also stable, there are children now who have not had an EUA for a year and a half, and I'm okay with that. Actually, I mean, I'm a little hesitant that I haven't done it, but there's no reason for me to do that. And they've grown up now. So that's one thing. Eye care has made a difference. Axial length has made a difference to our practice of EUA.
And just one more thing. There are a lot of people who say that when you put a speculum when you're measuring the IOP, it does make a change. So do you routinely do without the speculum?
Yes, when we're doing it under EUA, it is without the speculum. But I was interested in what happens in the preterms, and I couldn't take them all for GA only to do IOP. So I did them with the Alfonso speculum, because that I thought had the least pressure on them. So preterms where they're very tiny, the Perkins just doesn't go in unless you put a speculum. So there I use, but otherwise EUA is all without speculum. Once they're term, then there's no problem. Then we don't use it.
Thank you.
Again, talking about children, I had a child who I was allowing for applanation from age of 2, and at 5 years of age, for some reason, I was not there in OP on that day, and the person who saw it decided the non-contact would be more comfortable and did an NCT. And the NCT blast of air made sure that for the next 6 months, I was sitting and buttering up the child before he sat on the slit lamp again.
Yeah, I know. I can imagine. Yeah, because it's more fear. Once that fear is over and they realize it's not going to hurt. Toffees helps, Thomas.
Yeah.
Toffee behind is big Rishwat. They're very happy.
Toffees help, TV helps. Having a TV in the room helps.
Okay. No, they come with their mobiles. That helps. Doraemon helps. But toffees helps the most. Nothing helps better than toffees, I think.
Quite a few of these children will come and pick up the 90D cover and things like that and start. I just let them have it till they leave the room.
Yeah, absolutely.
Dr. Radharamanan, what do you think is a normal IOP for a less than 1 year old?
Actually, this is again what we were discussing. No, whenever you record it, you have to consider a lot of other factors. No, so that's the main thing. So, like Dr. Susmitha has explained, so it is not only the IOP we will consider it, because the way we record it, the other conditions, the anterior axial and all that thing. But definitely, if the IOP is more than 21 millimeters, definitely you have to be very cautious. But even with a less IOP, or sometimes you are using, sometimes you have to use the speculum, as Madam explained. Sometimes I lift the speculum little bit on the lid, because not to press it. So sometimes we cannot avoid that speculum. So I have to lift the speculum little bit, and I will be holding to some extent that it won't be extending too much on the lids also. So that way we have to change it. Sometimes it is so surprising. Sometimes when you set recorded at 24 or 26 in the IOP, then and with some caution when you record it, it comes to 18 or 17. So this is with a lot of caution we have to take that IOP.
Absolutely. I mean, but it's a great end if we even have one eye of the child perfect at the end of the story. That's what I would say, because congenital glaucomas that I have seen, quite a few of them are so asymmetric, we can't help but have amblyopia on one side.
Dr. Susmitha, if the patient is child is waiting, sometimes our problem is most of the time the anesthesiologist will ask for a delay in the surgery and all that thing. Then which is your first medical medicine, or even you are waiting for this thing, which medicine you will start it?
So brinzolamide, I found it to be safest in most children. I would avoid timolol in babies less than 3 months of age, even though we tell the mothers punctal occlusion and all that, but I'm a little hesitant. So brinzolamide is our first choice, and I do use latanoprost as well if we are waiting. And sometimes if surgery is not possible, if we can just do an LMA or something, Ken still is a great advocate of a limited diode laser cyclophotocoagulation as a temporizing measure. You know, for some reason under sedation or something is said to bring the pressure down until you can actually go in and do definitive surgery. Though that would also require some sort of sedation or anesthesia. But usually brinzolamide and latanoprost, and if they are older, then. So sometimes now, if they are older than 3 months, I've become even braver. With my heart in my mouth, I also give them Diamox once they're admitted and they're under me. And babies who were planned for a combined trab with trab, if I can avoid a trabeculectomy in a baby, I'll be very, very happy. And those are the babies where the cornea is clear over 2 days. And I then do so I'm lucky that our pediatric glaucoma clinic is Friday and my OT day is Monday. So I have 2 days to play with them. So Diamox also as temporizing if you want to. And what is described is scraping off the epithelium using alcohol and whatnot. I am so scared to do that, so I don't do that at all. If at all, I'll use Diamox. I won't dare scrape off epithelium in a baby and send them off after that. I can't do it.
Painful.
So this is what the Western world says. You scrape off, they put a well, put alcohol, scrape it off, do the goniotomy, give a contact lens. No, 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 no. I don't dare do all that. But Diamox, I used to be scared of. 25 milligram per kg in 3 divided doses works very well. So we send it to the APC pharmacist, 250 milligram of Diamox. They weigh exactly. They have a jeweler's weighing thing. They make the pudiyas or the little things for them. And you just tell the mother to give that little powder with honey or something. And it has worked. It's made me avoid a lot of combined trap with trabs and do a goniotomy, which I'm so much more happier about now.
Ma'am, can I ask a question?
Yeah, of course.
Ma'am, speaking about aphakic glaucoma again, do you routinely do pachymetry for these children? Because I have been taught that unlike adults, the central corneal thickness does not hold any value in pediatric glaucomas because it's very variable and surgeries can affect it. So when we do an EUA, sometimes we tend to do a pachy also for aphakic glaucomas. So
Yeah.
Look at
So
the
pachy for aphakic. So the difference of we do a pachymetry and keratometry for all our pediatric glaucomas, and if the cornea is cloudy, we do UBM for all of them. So our EUA takes 45 minutes, and the surgery takes 10 minutes, and the anesthetists hate us for that. That you write surgery, but your damn EUA, you don't leave the table until, because we do all of this. So what I've seen interestingly is in aphakic glaucoma, there's no corneal edema, but the cornea is thicker. So I'm a little unsure of what pressure we are recording, because I think that pressure is fallaciously high a little bit. So if I have a clear cornea, but for some reason aphakic glaucomas have a thicker cornea, maybe it becomes more rigid. I don't know what happens to it, but it is, something is wrong there. And if I have a 600 micron cornea with 20 pressures, I would sort of say, just hold on. And if the discs are fine, I wouldn't jump. But on the other hand, my PCG or congenital glaucoma patients they might have a 700 micron cornea, but there it's so spongy that it's fallaciously low. So there I'm scared of. So we do pachymetry for all, but depending on the cloudiness of the cornea, I would interpret what I'm recording. So since I'm doing UBM, if I see a lot of fluid and a lot of clefts, I know that recording is falsely low. But aphakic glaucomas, I've seen the cornea is thicker. But yes, we do pachymetries and all. We do pachymetries more as a pat your back measure. See, it was 900 and today it's 500 now. You just feel good. But that's one thing that
we have to see everything together, the IOP, the corneal clarity and the axial length increase, everything, and then decide whether the child, because recently we had a
and increasingly, when we started doing the keratometry in the OT, it is so interesting that you might have a 24 millimeter or 25 millimeter eye, and on refraction, the child is +5. And I'm like, how is that possible? And then you realize the cornea is 37 diopters. It's so stretched that the cornea is completely flat. So it's offset the myopia. So that's why I look at axial length more than change in myopia, because I've seen that the child may not change myopia because it's stretching horizontally rather than vertically. And I don't know which child is going to do that. So this is something else that we've seen.
And even the lens keeps going backwards.
Yes. Yes, that's
that
the lens
also
flattens.
adds.
There could be subluxation also, no? When
the lens
Nina,
flattens.
without subluxation, lens becomes like on plain glass.
Yeah, it flattens.
It's
correct.
Absolutely flat and goes backwards. So its power is reduced, literally.
Yeah. Becomes more hyperopic. Sorry, Nina, you were saying something.
Ma'am, recently we had a familial aniridia kid, a 5-month-old baby who was brought by her parents. The father has aniridia, he's on AGM. So the child, when we looked at the child in the OT, the child had one eye clear cornea. The other eye, we thought there was a little bit of corneal haze. And when we checked the IOP, one eye it was 12 and the other eye was 19. Though within normal range, there was a little bit of difference between the two eyes. And between the two eyes, there was a mild vertical covetous ratio disparity. Corneal diameter was also a little more in the eye with a less clear cornea. So we started the child on dorzolamide. So I think now looking back at the talk, it was a correct decision, I think, because there, as you said, it may not be the absolute IOP, which may be more important, or it could be relative also.
So one little take on aniridia. David Walton is a great proponent of prophylactic goniotomy, because if you have a family of aniridia with base pressures and bad glaucomas, and they're the worst glaucomas when they develop, then it's autosomal dominant, and that kid is going to become glaucomatic. So he says, while you have the chance and the cornea is clear, you please go in and do a prophylactic goniotomy. Just open up the channels and don't let. And his thinking is that it's the iris stumps which go back, and block the trabecular meshwork. And before that happens, you just open it up and clear it out. And interestingly, Dr. Vijaya ma'am spoke to me about a year or so ago, maybe some time ago. And she said that, look, the mother and the elder sister and another elder sister, and now they have this little brother. And pakka, this child is also going to go intractable. Now you tell me how to do a goniotomy in an area. And I said, my God, ma'am, I'm so scared because there's no iris. So we just talked about it. We looked at David Walton's paper. So you push the lens down and you just gingerly go in, whatever. And next morning it was like, Eureka, I did it. And it's been a year or so, year and a half, because we are talking on that. And she says that boy hasn't developed any glaucoma as yet. So one take is if there is a hint of 1920 pressures, little bit of increase. So let's just go in and, let's go in and do it. I would now. Of course, maybe 2-3 years ago, I wouldn't. I would give medical treatment. But invariably that fails. I've seen these glaucomas.
I did refer the child for a second opinion to Shankar Netralia because I wasn't very happy with everything.
So ma'am, I should prophylactic goniotomies for familial. We've done it for this family that we looked at. The younger fellow did not have intractable glaucoma, but I told the father, I'm not going to wait until he becomes like your older kid. So it's easy for parents to relate to the fact if you tell them, look, you have one who you know is blind. So let me do something with this guy and try and, this thing is vision. So these are just things which, little nuggets, which
and the other thing is limbal stem cell deficiency is there in most of these children.
Yeah,
so long-term
correct.
medical therapy is only going to add to it.
Yeah.
That's
why I want to avoid a trabeculectomy as well, because of the limbal stem cell deficiency, because we'll be using MMC over that. So goniotomy is a wonderful thing. I'm so happy to have.
So that was one thing which was confusing me, whether the corneal clarity, lack of clarity was because of the limbal stem cell deficiency, or was it because, but since we thought there was an IOP difference and Kabda's ratio was definitely higher, we thought definitely we will err on the wrong side and think it as glaucoma unless proved otherwise.
Because aniridia keratopathy can also be very bad. The epithelium becomes so loose and horrible over time. So I think reducing the pressure by any means is a good thing to do. But yes,
Can I ask something?
Yes, ma'am, please.
Actually, when you follow up these aphakic glaucomas over time, as you said, CCT is always very high, 600, 700. Do we correct it like the nomogram we give, like the adult nomogram? Is it okay if we correct it to the same nomogram?
So ma'am, even in adults, we don't actually use a nomogram. We just sort of keep it in our heads that it's an average or a thin cornea. And for OHDs, like we say, if it's a thick, so it's usually between 525 and 575 is what we call an average cornea. Anything more than 575, we take it as thick, and anything less than 525 is thin. So we just keep it in our heads that if it's an ocular hypertension and the discs are fine and the cornea is 600, most likely this IOP is fallaciously a little higher and the other is lower. But ma'am, we don't use a nomogram in adults also. And likewise in a child, I would tell myself if it's 21 pressure and a 700 micron cornea, I would think that, let's hold on. Let's just look at the disc. I mean, that would be my first criteria. Keep looking at the disc, maybe take disc pictures. On table, it's very easy to take it through the gonio lens. We don't have a fundus camera in the OT. So I just use the middle of the gonio lens. If it's dilated, it's very easy to take it on the microscope. We have the pictures. I would follow up on the disc, ma'am, but I wouldn't treat.
I think it's been a long, nice session. Very fruitful. I think if we let it go, it'll go on till evening.
Yes.
If we're having a nice discussion here. And I especially thank Dr. Susmitha for that wonderful talk. And I'm sure everybody sitting here will see through it again, because there's so much information that we need to pick up, which are actually very important as well. It's not just textbook coming in. And thanks to the panelists, Dr. Radharamanan, Neena, Laila Madam, for actively participating in the discussions. Thank you all. Srini, thanks for the opportunity to conduct this.
Thank you, Thomas. Thank you.
Over to you, Suresh, for further proceedings.
Thank you, Dr. Thomas George and all esteemed panelists for a very interesting and educational session. We have come to the conclusion of the module 3 of the CME series. Now I invite Dr. Rakesh, Joint Secretary, Kasaragod Ophthalmic Society, to deliver the vote of thanks.
Thank you, Dr. Stephanie. Yeah, this is just an invitation from Ksos to join the online journal club on 8th of March. I'm sure the PDF file will be circulated later on. Thank you. I go into the vote of thanks. I first of all thank Dr. Arup Chakravarti, President KSOS, Dr. Gopal S. Pillai, Honorary Secretary of KSOS, Dr. Srini Adalkon, Chairman KSOS Scientific Committee, Dr. Sujit Nayanar, Member Scientific Committee. Thank you all for giving us this wonderful opportunity to host this webinar. I thank our eminent keynote speakers, Dr. Shantha ma'am, Dr. Rajul, Dr. Swathi Upadhyaya, Dr. Susmitha Kaushik for their wonderful and detailed presentation. Thank you all. A special thanks to our chairpersons, Dr. Bindu Ajith, Dr. Kiran Gopalakrishnan, Dr. Saikumar, Dr. Thomas George. I thank our eminent panelists of all the 4 sessions, Dr. Ranjini, Dr. Manju Anup, Dr. John Davis, Dr. Thomas Arun, Dr. Meena Nair, Dr. Meena Gopinath, Dr. Venkatesh, Dr. Ajitha, Dr. Thomas George, Dr. Neena, Dr. Radha Ramanan, Dr. Laila Mohan. Thank you all. I also thank our conveners, Dr. Suresh Babu sir, Dr. Ganesh Maya sir, and Dr. Mariam Verghese. I thank our President, Dr. Rahim, Secretary, Dr. Suresh Babu, Treasurer, Dr. Ganesh Maya. Thank you all for putting in so much of hard work. I also thank our Master of Ceremony, Dr. Stephanie, for doing a wonderful job. I also thank all the members of Kasaragod Ophthalmic Society for joining us. I also thank all the participants who have joined us on YouTube and Zoom. I thank the technical group of KSOS. I also thank the Sun Pharma group for sponsoring this. Thank you all, and hope to see you in person in next physical meeting, hopefully. Thank you all.
Thank you. Thanks for having me.
Thank you. We'll wind up.
Yeah.